Clinical science, like 12 science, in the last and this the other side, people or like diabetes. Or and less big outcome. In thank you. As we all know, this chairman so the list of questions. But I would like to say that musculoskeletal problems are very common in application. We know about certain things like hip contracture, frozen shoulder, common, high muscles, osteoporosis, etc., etc. But you even have a list which make us very scared. As a very complicated practice, as well as a medicine, is not permissible, but I need your comment. Since it is a very common problem, is it possible to prevent these things in a diabetic person? I mean, control that is understood. But other than that, can I do anything so that these problems can be prevented? Because of the shoulder and difference contracture, even osteoporosis is a very, very troublesome problem. So you comment, Dr. Umesh. and also presence in the where specialist letter problem that are used so what you comment on this issue? So thank you. What's true? All are beautiful. Something to see did you just meet example during the external conference? So all of this, and again, I ask this question. I just comment on this issue because the other person is no scope of question. So thank you very much. Thank you.
हमारे विद्यार्थी को सुंदर तरीके से दर्शाने का काम करते हैं और पूरी and now your own set become next section section and in order to motivate and speech motivate
Good morning, everybody. This session is hard in the Constitution. And the chairpersons are Dr. Is Dr. Amin? Dr. B. Kumar is Dr. Nitish is here. Dr. Sushant Kumar from Patna. For chairing this session. Dr. B.K. Sharma. Dr. Shamsad. For this session, we have 4 speakers, but there will be a slight change in the schedule of the speakers. First of all, we'll invite Dr. E. Prabhu, and I will request. The subject is heart failure in elderly.
Good morning. Dr. E. Prabhu is a founder and he is the master of clinical nuclear imaging department. His head is
Good morning, most respected Chairman. In fact, I bring with me the warm greetings of the physicians of Association of Physicians of India, Tamil Nadu, as its chairperson. I consider this as a
Also, the founding fathers of the APA, Dr. P.P. Thakur, I got an opportunity and get blessed by him. And it is an amazing experience to be under the virtual leadership of the medical education and the practice of medicine in general. In fact, I like this opportunity to share a few of my thought process about the challenges as we physicians face in management of heart failure in elderly. There are a lot of, as physicians for a bit of time, we already know that heart failure is more commonly prevalent as and when we grow older. In India, we still have rheumatic heart disease in many parts of our country. Hypertension, diabetes, ischemic heart disease, coronary heart disease, everything is a major cause of heart failure. And elderly people suffer from preserved ejection fraction, heart failure with HPF, and with multiple comorbidities and atrial fibrillation and all, that may limit the symptomatic improvement. They are already on major drugs. Many of them we visit, they'll be taking a handful of drugs in the morning, handful in the afternoon, handful in the night, in addition to a lot of Ayurvedic preparation, home remedies and all. And there may be other comorbidities like acute kidney, like chronic kidney disease, bronchial asthma, COPD and all. So many other medications that we have to rightly balance when we are managing them. There are other psychological, so many other untold amount of factors that will intervene in the management of heart failure in elderly, socioeconomically. And some of them may have a friend who, their son or daughter, whose friend is a physician in US. They will be advising something in parallel to what we are going to treat. So many other challenges we normally face. Heart failure, as previously it was simple. Heart failure is a preserved ejection fraction and heart failure with reduced ejection fraction. Then as and when technology advanced, the AHA revised its guidelines as HRF, moderate reduced ejection fraction was inserted, then preserved ejection fraction. Then it was subclassified with so many other based on the LV ejection fraction. Then nowadays we are also hearing about improved ejection fraction, heart failure with improved ejection fraction. Talking about elderly, it is very difficult to set a time limit, age limit for being an elderly nowadays. So when we went through the data about the age associated risk factors, in our practice we suddenly see a lot of government people who become older overnight. 50, 60 years they go older, 61st year we find that they have become old. But generally, because of the advancement of science and technology, nutrition status and all, the average person in most of it is about 90 years. As a consequence, the number, the costs, one of the price we pay for living longer is hard. And we can see that the numbers are higher in the oils and the sales. The with the partners as when the patient become older. These are the risk factors: obesity, hypertension, diabetes, current smoking. Some itself is a predisposition for heart failure. The clinical scenario. This is one condition where normally you come across with the COPD, diabetes, type 2 medication, smoke for more than 30 cigarettes a day. And use on our regular drugs because we are in a underwent nutrition and medical mechanics are 40%, you underwent angiography, are deceased. And after 15-20% of stress pain, PCA was done, the patient became more symptomatic and he was put on optimal medical treatment, diabetes medications and hypertension medications are fully optimized. And then especially when he compares his as well as 19%, he had dilated ventricles. They also have sufficient effect in antiseptic inferior lateral leads. Fixed was put in anterior wall. And it was now standard routine of medications, and now is asymptomatic is on regular follow-up. In one clinical scenario, we get the other one is a female 84 long-standing hypertension, diabetes, increasing breathlessness, and dyskinesia. Then now we see the person herself. She has software engineer son who is in States, and the medical doctor who is in the UK. And as a consequence, she was not able to she was all alone. And she used to go to the neighborhood shop for purchasing the provisions. After she was in, she was increasingly difficult. And her friends and the caretaker takes care of her support once in a while. And she was put on very good medications. She had hypertension, diabetes. CM creatinine was on the higher side. Cholesterol was 330, LDL was high, and the BNP level was 430. Risk factors. We can help us to diagnose heart failure. Echo abnormality, and it was SF, and it was about 52%. The third scenario is a male CKD with instant disease, heart failure, diabetes, shortness of breath, pregnancy, aging, 6 months for 6 month duration. With the person denied that he was proven easy confidential to any other such complaints. The evidence is asymptomatic. PCG, sinusitis, RBD, and all. And the blood test on rating them and responsible for NPPM was elevated. These are the common clinical scenarios we can come up with when we are managing for There are few challenges in the diagnosis of heart failure in India. Parents of abnormal systolic function who have more than more than 30%. Non-systolic function with 4 indicates the possibility of the next 5 years in the the other symptom also be cause of increasing severity of heart failure. Only thing is we have to use what are the investigations we have to objectively evaluate heart failure and carefully select the patient who are benefited. If you are planning for intervention, and we have to keep into so many considerations, including the cost factor to keep into while handling heart failure. And the is increasing the age and consequently and heart failure management. Strengths and weaknesses. So I will take on from clinical because we do not have researchers and we not have practitioners. Women with heart failure. This is something which we are wanting because most of the women don't complain. And we don't understand the heart risk. And we often come to clinical symptoms where we want to implement symptoms. And many of them which is and all there is
This concept is not will have as a consequence when and this when this is understand where it's this is we can assist my we can understand the And this simple and this ICC and and the situation we can CC level and it's I think and some my this is where it is not when it is and also we can with some Thank you very much. Thank you, Dr. for your excellent talk. I they are CAD, but it's still the problem. Yes. But and they have starting that is deserving of successor in this expression. That is there. When do you in I specific indication. In the there
Thank you, Dr. Prabhu, for the brilliant talks.
Yeah. One more thing, when we consider nuclear medicine for our medical treatment, usually we are not prescribe nuclear medicine for every kind of heart failure. There are specific guidelines. First of all, when we need to say that one thing mismatch, there are not. So usually we have to angiogram and it is something that is documented and not sure whether the patient or not. Secondly, when we need to document stress induced ischemia, if it is leading to heart failure. And third, in the third context where your statement might be partially correct. These are the patients, especially CKD patients or those patients, and angiogram would not be done. Those patients who are heart failure. So these patients, it's quite difficult. But when you say that you don't need heart failure, I don't think you can have this. Thank you.
Thank you, Dr. Prabhu. I request
When this conducting hardware, but patient does not see but allows sympathy. So in that tasting in second population of section is normal. So, as a physician in a community practice, if we don't have access to all the modern administration modalities, our the clinical information, the way somebody walks in, talks in front of us, choice, all the clinical skills that are put into forth, that is the most powerful. But then we need certain evidences to convince the patient to make them ideal to line up and then we need some investigations. But investigate that as we optimize, depending on the availability, affordability, and so many other factors with the patients. Thank you.
Thank you, Mr. And I would like to request Dr. B. Sharma, sir, and one of the speakers, Dr. E. Sir, as well as I request for Dr. E.
Like
जहाँ से कॉन्फ्रेंस हो रहा है वहीं चलना है।
yes, thank you. आप लोग कर
Thank you. Next speaker is Dr. Mohan. Dr. Chandohan, please introduce. The subject is heart failure with preserved injection text.
We are heart itself cannot but I will and guidelines. So start with so hard we need not science. It's not so cheap. So heart failure has no clear-cut subtype of heart failure which we comments in our daily practice and when we see the patients. And two are very clear subtypes. One is reduced ejection fraction and one is preserved ejection fraction. It is since our 2013 CCDCon guidelines came before that also. Initially it was known as systolic and diastolic heart failure, older than heart failure. But later on, the consensus should be classified as basis of ejection fraction. So two clear denominations for one is reduced ejection fraction, in which LVEF is less than 40%, and with preserved ejection fraction, in which LVEF is more than 50%. And it is mostly because of systolic heart failure, but from failure, ejection fraction is gone down, and in preserved ejection fraction, it is because of the diastolic function, the relaxation of the myocardium is impaired, the filling is impaired, and it is preserved the ejection fraction is preserved. And then in 2015-16 guidelines, one mid because of the gap, less than 40%, more than 50%, but the gap of 41 to 49% was there. So it was mainly ejection fraction with heart failure. It was in 2022 and it was that reduced ejection fraction, preserved ejection fraction, and mid ejection fraction. Then in 2028 guidelines. One more term, heart failure is improved. Why? Because it was evident, it was shown that the category of heart failure either reduced or either it's never same. Preserved ejection fraction tend to reduce ejection fraction after some time, or if there is a precedent factor. Sometimes the reduced ejection fraction can be moved to preserve ejection fraction or improve to preserve ejection fraction. So now the trajectory of heart failure, like our sir showed in last image. So the improved ejection fraction is said when the previous evaluation ejection fraction was less than 40% and subsequently the ejection fraction improved. So now the latest guidelines talk about the trajectory of heart failure, which gives you an initial evaluation and subsequent evaluation.
If initially when the ejection fraction was reduced, it can move in direction, it can reduce further and remain in the same category, or and come into ejection fraction. Sometimes patient is we see a lot of patients when heart failure. Mid-range can go anywhere. It can go so it can be to mid-range. And result, if there is diabetes according to that, diagnostic algorithm was given. Diagnostic algorithm, we assess, we diagnose heart failure as a clinical syndrome. We see the echocardiography, EF is assessed, and then we put them in this category. So the proportion of it is being shown, the proportion of reserve ejection fraction is increasing because of the comorbidities and increasing living age of the patient. We are coming across increased population of mid-range and preserved ejection fraction. When it is diagnosed clinically preserved ejection fraction, no, you cannot diagnose clinically because clinically you can diagnose heart failure. To say 22 ACC guidelines, first time a clinical is which has 6 variables and there is a support of more than 6 or less than 2, and this gives you a likelihood of preserved ejection fraction heart failure if there is. So what are the variables? Obesity, natural fibrillation, age more than 60 years, treatment with antihypertensive medications, and echocardiographic parameter of diastolic functions and systolic pressure. These 6 variables are used. If it is less than 2, the likelihood is very low. If it is more than 6, likelihood is very high. Now, what is the pathophysiology of heart failure? Like it is not but diastolic dysfunction of the patient, systolic function is preserved, but diastolic, the relaxation of the myocardium is impaired, and so the filling is impaired, reduces, and the diastolic relaxation increases. When we see the epidemiology, we see that if you see the preserved ejection fraction, more than 55%, it is subsequently high. It is significantly high. It is 74, while the ejection fraction is 68. Women are significantly higher in this category, if we preserve ejection fraction. And if you see diabetes, hyperlipidemia, these are the high numbers significant. So this is the precipitation factor of the positive effect of the preserved ejection fraction. You see, 60% of the heart failure and 20% of Indian heart failure patients have heart failure preserved ejection fraction. Compared to reduced ejection fraction, the patient has preserved ejection fraction are older, more likely to be female, and more likely to have associated comorbidities like hypertension, diabetes, and atrial fibrillation, and non-cardiac comorbidities like CKD and malignancies. Now, when we come about, this is our evaluation. This has nothing very challenging. Once you diagnose clinically heart failure, after that only one thing to do is echocardiography and assess the EF. But the main challenge in heart failure preserved ejection fraction comes with treatment guidelines. Since before 2022, there was not much to offer for a patient with preserved ejection fraction as far as pharmacology is concerned. For reduced ejection fraction, we have a number of drugs for mortality benefit, morbidity benefit. But preserved ejection fraction, we are limited. So first, randomized control trial for non-pharmacological, which was from 2002 to 2007. So exercise is one of the most important factors to prevent patients who are at category 1, category 3 at risk, or with risk factors to prevent heart failure with preserved ejection fraction. Physical activity, that also aerobic physical activity is more important to prevent the progression of diastolic dysfunction and prevent heart failure with preserved ejection. That's why a patient who is having hypertension and diabetes but no cardiac comorbidity or no dysfunction, he should always be encouraged to engage in some sort of aerobic physical activity to prevent or to delay the progression of heart failure with preserved ejection fraction. But as I said, for reduced ejection fraction, so many guidelines, so many drug classes, to treat, to reduce the progression, to reduce the morbidity, to reduce the mortality. When it comes to preserve ejection fraction, we are there. So we took a case. A patient, Mrs. Lakshmi, who has hypertension and type 2 diabetes mellitus with peripheral artery disease and chronic kidney disease, lot of comorbidities are there. She presented with complaints of fatigue, weakness, clinically diagnosed heart failure, and her echocardiography 50% means preserved ejection fraction heart failure. Here, what is the things? What are the pathophysiology is going on? Insulin resistance is there, dyslipidemia is there, hyperglycemia, family history is there, which angles or which sync with the pathophysiology of heart failure, of myocardial infarction, toxins, idiopathic arrhythmia, infiltrative. And what are the common risk factors? Age, sex, race, hypertension, and obesity, and leads to diastolic or heart failure with preserved ejection fraction. Why we are stressing more on the oxidative stress and the association of diabetes with heart failure? Because very recently in 2022 or 2021, to be precise, few trials have shown one class of drug which is giving us promise to be the first approved drug to reduce the morbidity and rehospitalization and CV composite death in a case of heart failure with preserved ejection fraction, which we never had before in past. What is that class of drug? It is an anti-diabetic drug, which is initially used to reduce the hyperglycemia in type 2 diabetes mellitus, but it is shown that it reduces CV composite death, it reduces rehospitalization in patient with heart failure with preserved ejection fraction. What is that class of drug? That is sodium glucose transporter 2 inhibitors like SGLT2 inhibitors, and they have shown to be associated with heart failure outcomes, glycemic control, blood pressure, body diabetes. What it does? It has kidney effects, it has metabolic effects, it has blood vessels effects. It helps in glycosuria, diuresis, natriuresis, insulin sensitivity, stiffness, oxidative stress, which these all physiological dysfunction of myocardial dysfunction, they are hindered. So first study for dapagliflozin was delivered by which showed that dapagliflozin has mortality benefit in patients with reduced ejection fraction. But after that, a subject of heart failure who had reserved ejection fraction, the separate arm of the trial was the delivered trial, which showed that the preserved ejection fraction, where the population was more than 50 years, EF was more than 20%. They were put on placebo and one arm was put on dapagliflozin. A lower risk of primary endpoints, lower risk of CV death. We don't see because of heart failure. CV component of death are taken as primary endpoint. They have not separately taken deaths of heart failure, CV component heart death, fewer total were seen, and similarly scenarios of adverse outcome with less. So this was a little detail about delivered trial. Before that, the trial which came was the Emperor result. First Emperor trial which showed that dapagliflozin, a class of SGLT2 inhibitors, was shown to reduce mortality, reduce ejection fraction. But after that came Emperor result trial which showed that preserved ejection fraction also SGLT2 inhibitor dapagliflozin is beneficial. Then in a sprint trial, when we take a subset of patients who had ejection fraction more than 40%, it showed that strict BB control is better outcomes. So blood pressure control is very important. Then in other class of drugs like mineral corticoid receptor inhibitors, which was still top of trial, we are in sharp result trial. In we did not show to significantly reduce CV death and patient with preserved ejection fraction. There is a subset of patients who had increased nitric oxide and on the lower side of the ejection fraction. Like 40% as the cutoff, we take it and preserved combined. So when we take patient less than 40% and more than 40%, so ARBs, MRAs, and an army group of class, they showed improvement in patients who have higher baseline anti-TB, and on the lower side of the ejection fraction, like 45%. When we cut off as 50%, like more than 50%, they did not show much of significance as far as CV outcomes are concerned. So this is the guidelines which came in 2020 for preserved ejection fraction. We can see the patient in preserved ejection fraction. First and foremost, class 1 is hypertension control. Class 2, SGLT control. So most promising is treatment of comorbidities like heart failure, diabetes, hypertension, diabetes. Class of first to be is SGLT. Treatment of hypertension, whatsoever may be the protocol for any patient is applied on this patient also. After that, MRI or RR and ARBs, they all fall into weak, so not so promising. So again, similar picture, simplified one. If symptomatic clinical diagnosed heart failure patient with more than 50%, give diabetes. For symptomatic benefit, give us for morbidity and mortality. Rest all, if patient has higher slide and lower side, give MRI. So better. Now what we should do is just add and our outcome will be better. So this was a basic overview for evaluation and management of preserved ejection fraction. I think in this much time I can cover this much only. And I like clear your second moderators if anything this is. Hello. So like diagnosis heart failure a patient comes with typical features of preserved ejection fraction. First, he should have the heart failure should be there. After the reduce ejection fraction. So preserved ejection fraction, if you think the patient has typical symptoms of heart failure, which we all, if patient is having heart failure symptoms, after that the question arriving, the patient is having transparency to get heart failure more than 50%. Now to make it easy, six variables. Concretely diagnose these 6 variables. Score is 9, if it is more than 6, you can say with higher likelihood the patient is having heart failure. Or you should have to have a high threshold for diagnosing a patient. Some 15-year-old female only hypertensive, uncontrolled hypertensive every time she comes like what I have seen in practice. She some clinics for some fatigue and dyspnea for so long, and she has given all types of supplements like multivitamins and nutrients and vitamin D. This is the subject of the patient. For that, you should have a higher threshold. Sorry, suspect heart failure is the is her ego is done, which should normal, but that time you start giving you are saying yes. I'm as a heart failure, there's all of this. Anti-TB is a very good marker. So you can always help of anti-TB as a supplemental diagnostic to clear your diagnosis. But I still believe that if you diagnose heart failure, antibiotics is when you're getting the patient is heart because of the heart failure or non-cardiac, that helps more. And with reduced ejection fraction, it has therapeutic value also. Secondly, preserved section like again and again, those classes of drugs which are on the 2B classification, you have to identify the substance who have higher baseline and the lower scale. we cannot see self-identity as a diagnosis. To guide our treatment. I want which are now like now the guidelines are heart failure. There are so many classifications to classify heart failure. Stage wise, symptoms wise. When we think about clinical syndrome, it's only as given as a cutoff to classify patient as we reserve sir, I say cardiac function. So I not how
So we'll have one common knowledge.
I think the things have changed a lot when the universal definition of heart failure was proposed in 2021. Now it is not really to go through the full pattern of tests to diagnose heart failure. We need just any scientific symptoms of heart failure. Apart from that, whether it is anticoagulable or ejection fraction or echocardiogram, their diagnosis of heart failure is made. Now, echocardiogram is necessary to diagnose whether it is ejection fraction or a preserved ejection fraction. So, and also when we need to go through the full pattern of tests. So when we need to follow our patient, then we need all the tests which are required. But for one or along with symptoms of heart failure.
So heart failure from the very first definition is all we diagnose clinical symptom. So the diagnosis of heart failure is always clinical to substantiate your diagnosis and classify it according to the guidelines. We take anything to BPPA to the rest is still a clinical symptom.
Thank you, Dr. Now the next step that will be I request Dr. Ccdsicon to come and
Yeah, our next presentation will be Dr. Sajid Ansari, who is from Lucknow. He has a lot of experience when it comes to management of heart failure, especially, and he will talk on heart failure management in pregnancy. Yeah, I think Dr. Sajid Ansari will like now. So him.
Okay, should I share my PPT now? Am I audible well? Yes, here we go.
Welcome, Dr. Ansari.
Thank you, sir.
Go ahead.
Thank you, sir, and thanks all these dignitaries from this CCDSI. I have seen on the dais Professor Rai and other dignitaries. Really great pleasure. I am since last 1 year associated with the CSI. My senior Dr. Barmani sir, Abhishek and everyone, Dr. Mitunjay sir. Friends, you know the topic given to me is heart failure during pregnancy, and this is time given to me is a 15 minute, and this is a subject that need maybe more than 15 hours to discuss the very well. Okay, so friends, we know we divide our discussion in terms like already some subject having problem before conceiving, and what is the risk factor associated with pregnancy, and what the hemodynamic changes occurs in the pregnancy. That's the more important. Friends, we know one thing, that you go and see the data regarding the high risk pregnancy, it is gradually increasing day by day, and there is some definite reason behind it, some social reason, some reason desire to burden disease burden. And important is you see the possibility of pulmonary hypertension. One thing is, if there is an absolute primary pulmonary hypertension, okay, that is absolute contraindication to pregnancy. But what about in the secondary pulmonary hypertension, secondary to cardiomyopathy? You know, peripartum and postpartum cardiomyopathy is a very important. Somebody already having some valvular heart disease and she get conceived, what is their further course of treatment? So who is on the more risk patient with a perinatal morbidity and mortality, low APGAR score, and prolonged neonatal intensive care unit stay of the mother and fetus both. So in the past decades, as I told, this is the increasing incidence day by day, that postpartum period increases by the 24%, and complication in such pregnancies by the 18%. Two things are important: duration of hospitalization, the high risk pregnancy is increasing day by day, and postpartum period duration and peripartum is increasing, and complication high risk pregnancy is increasing. And heart failure does not perceive only when patients subjected to NIH class 4. They are the early symptom also, and that should be came in the notice. Important thing is there is some definite physiological changes in the body, and that should be always in the, while doing echocardiography, and because of hyperdynamic circulation we are finding high velocity TRZ, and we go for a conventional calculation of PSP, that might coming 50 or 60, that might be in the level of mild pulmonary hypertension, but that is because of hemodynamic changes. So we should be aware of what the hemodynamic changes is going in this maternal body. So there is an increase in plasma volume leading to physiological anemia, increased maternal heart rate, increased arterial blood pressure, decreased systemic vascular resistance. That's why this causes increase in the cardiac output, and increased cardiac output as discussed beginning in the early pregnancy because of an increase in stroke volume, and it is maintained further by way of tachycardia. So these are few very important changes. There is increase in cardiac output. Somehow this created some hypercoagulable state, sometimes also changing the systemic vascular resistance. So this should be taken care in this notice. So this is maternal cardiovascular physiology during the pregnancy, labor, and early that pregnancy, there is increase in cardiac output, heart rate, stroke volume, and plasma volume, and LV dimension. But that is a transiently, and that the reversible. If it is persisting, that is land up into cardiomyopathy, and there decrease in systemic vascular resistance during the labor. Same thing is happen, but the patient is under physiological stress and early puerperium and the peripartum period. The increase in systemic vascular resistance, and here that BNP is a little bit raised, and reason behind this, my previous speaker was discussing. This is the hormone NP and BNP release only because stretching of myocardial fiber, and at this time stretching of myocardial fiber is on the highest level. So NP and BNP, but that is not absolutely pathological, and there is a decreased cardiac output in the early perium. So maternal and cardiovascular physiology, pregnancy, labor, and early as I discussed in nutshell, that is going to happen. And what the cause and timing of heart failure? If you see, broadly divide this heart failure in the maternal group itself, pregnancy can lead to heart failure. Their prior disease, especially valvular disease, like me practicing in the cardiology, and not my major patient in the from this corporate sector. So we have a lot of patients, they are coming to us during the primary pregnancy, and they are having the mitral stenosis, the pulmonary hypertension, and believe me, they know that she is having mitral stenosis because of social reason. These things is not going to explain to the at time of marriage, and when we are taking the history in the secretly, then the lady, yes, I know I am, because the marriage necessary, and I go for the marriage, and she is having pulmonary pulmonary hypertension, mitral stenosis. So that is a very, very important thing. Mitral stenosis is one of them. Then pulmonary hypertension, isolated pulmonary hypertension, and primary pulmonary hypertension, vasculitis sort of things is more common in a female, we know, of ischemic origin, and congenital heart disease. There is congenital heart disease of adult also that persisting, and that is the one important causes. So divided the peripartum dilated familial hypertrophic ARVD myocarditis and chemotherapy related like this ischemic heart disease and chronic ischemic heart disease. Pulmonary hypertension is, if it is a primary pulmonary hypertension, really this is a dangerous story. Some valvular heart disease, all kind of valvular heart disease, and congenital heart disease also. Causes of heart failure is mentioned with the different trials, and this ROPEC and national inpatient sample obtained through this healthcare cost. But if you go and see the data in the detail, what the exact story? So there is a peripartum cardiomyopathy, and this is going to increase. Important is how to overcome this problem, and that is the more important. So if you go and consider timing of heart failure, so if we think of peripartum cardiomyopathy, or the peripartum cardiomyopathy can occur at any time of pregnancy, but most commonly occurs in the last trimester or within the 6 weeks of postpartum period. However, peripartum cardiomyopathy has been described as a late as 5 to 12 months of delivery. Also, late onset was associated with 2 to 3-fold increase in risk of maternal mortality and MACE. Here, one thing is very subject to debate and discussion. Is it true that all the peripartum cardiomyopathy is reversible? No, this is not absolutely reversible. This entirely depends on the comorbidity of patient and what is going to happen in and that part of time. I have so many patients, they are having poor LV function, improving LV function, still having some high and LV filling pressure, the advanced diastolic dysfunction, but they are improving and doing gradually well. Same thing is here that I think this is a risk factor for heart failure associated with the pregnancy, as I discussed, that the incidence is the highest among the black women and the lowest among the Hispanic women, as it is true for the maternal heart failure overall. Association between PPCM and preeclampsia is well established according to approximately 1/3 of the women. If you see this data and diagram, that there is so many this factor mentioned, and you know right now, because of this corporate culture and everyone thinks to be when I will become stabilized and get married. So late marriage is very important, because in the 35, sometimes 35, 36 like this. So advancing is the one important concern. Anyway, there is some modifiable risk factors and non-modifiable risk factor also. So in the modifiable, obesity, tobacco use, alcohol, then hyperlipidemia, hypertension, and this sort of things. And there is some obstructive risk factor also, preeclampsia, eclampsia, gestational hypertension, gestational diabetes, the important concern. Then placenta previa, abruptio placenta, and multiple gestation, and there is comorbidity, as I discussed, hypertension, CAD, NYHA class 2, pre-pregnancy heart failure, and CKD in the diabetes. So if this all together is there, there is definitely worse outcome is there, and no discussion about it. But how to overcome this combined effort from the gynecologist and this physician and the cardiologist. So I think when we're going to diagnose the peripartum cardiomyopathy, one thing is the timing, as I discussed. The most common is just before pregnancy up to 6 weeks, and if there is no history of clear-cut shortness of breath, and if there during the antenatal period there is a clear-cut ECG, and I know that right now a smart gynecologist always in the every trimester they are asking for the echocardiography. So if previous echo is looking normal, so you make it that it is of the recent origin. Anyway, development of heart failure, you take the clinical history and the risk factor, as this is frequent descent, high blood pressure, prior toxin, and use of certain medication to prevent the premature labor. If you're going for these causes, undefined post-viral illness, abnormal immune response, nutritional deficiencies, coronary artery disease, small vessel disease, defective anti-oxidant defense, and genetics. One thing not mentioned here, Takotsubo cardiomyopathy, that is not entirely without pregnancy. Sometimes because of over stress and that is, we know, apical ballooning, and that is specific for the diagnosis of this echocardiography where exactly presentation. So that can be stress induced cardiomyopathy can be transiently happen with this kind of patient. And then dimension, of course, if you diagnose the dilated cardiomyopathy, peripartum diagnostic criteria is same: LLV dilated, high and failing pressure, usually diastolic dimension more than the normally we know this should be more than 5.8 to 6 centimeter. I'm not telling you about the index LV dimension, and an ejection fraction, it should be less than at least 40 when you are telling that LLV dilated and low ejection fraction. Up to anyway, we know the right now newer criteria for half ref, even divide 3-4 category by ACC, reduce ejection fraction, mid-range ejection fraction, improve ejection fraction. That you can apply here also. That is for clinical concern, how our patient is behaving. As we discussed, we go for the differential diagnosis. Takotsubo is the very important one. Familial cardiomyopathy, genetic counseling needed. Pre-excitation syndrome and tachycardia induced cardiomyopathy is very important one, and you never forget recurrent peripartum, pre-eclampsia, hypertrophic cardiomyopathy. Here LV is not dilated here because the gradient is there, and there's a high and feeling pressure. Myocarditis, ARVD, LVOT non-compaction, some chemotherapy, and that's why this that whenever you are going for this chemo, there is a mandatory to go for the stress imaging and say the LGL stain, valvular heart disease, congenital heart disease, as a tachycardia-induced cardiomyopathy, hypertensive heart disease, all these sort of things should be always in the pulmonary embolism. Acute pulmonary embolism is not supposed to be, I mean, because in that condition, usually right side heart is dilated, but if you diagnose a dilated cardiomyopathy, that things is again. So sign and symptom usually started with tachy, fatigue, dyspnea, edema, middle edema, shortness of breath, dyspnea and exhaustion, orthopnea very important, rails, S3 heart sound, cough, and hepatosplenomegaly. So no need to discuss this against audience here. Yeah. What is the outcome? So peripartum cardio 4 cases reported with a different outcome. So I mean, outcome is as I discussed practically in my practice also. A few percent really they are recovering well within the 1 to 2 week after this, but few are not getting well. So this is data, and this is a very small data, but this in practical this is going to happen. So serial monitoring during a subsequent pregnancy. So I know a smart gynecologist starting from this post conceiving from the every trimester, they are getting thorough cardiac investigation, and I have seen that from the corporate culture in the last trimester of pregnancy, they are asking from the this pro-BNP also, anti-pro-BNP also, and they try to explain in which category you are falling, because in the era of this. Everything is going for the litigation, so it is important to be on this safer sides. So this clinical assessment, echocardiogram, BNP should be performed at a regular interval with any concerning symptom, and this has been shown that how you judge it clinically. Coming to important aspect, how to treat the patient, and this is a big challenge. Suppose the patient of mitral stenosis already known, and she is in atrial fibrillation, she needs some anticoagulation. How will you treat him? So there is a guideline for this, and no need to discuss in the detail here, but some dose modification and some things needed like this. So conventionally, if there is some emergency, something, ideally in the first trimester, you should try to avoid whatever possible. In the second, third trimester, if there is needed, you can go for loop diuretic and some beta blockers and low molecular weight heparins, but don't give ACE-ARB and aldosterone. And whatever possible, you go for the early delivery. During delivery, plan ahead with a cardio obstructive team and fully equipped team. If unstable, consider hemodynamic monitoring and optimization. Caution for fluid overload, especially after the delivery. Yes, and after pregnancy, we know just to keep in the mind that if breastfeeding, which drug should be avoided. Otherwise, you can come for a conventional treatment. And here the issue is anticoagulation for the LV thrombus. Usually LV thrombus, I think in the cardiomyopathy, my cardiologist friend is sitting here. LV thrombus is not a very common. I find very few apical thrombus, and when we send it for the intervention, that patient is gone. The problem is LA thrombus while a patient treating with this, especially post mitral stenosis, atrial fibrillation, and rhythm disorder. So again, we can start the anticoagulation. Problem is the breastfeeding, and now here the debate and discussion that in the era of ARNI and SGLT2 inhibitor in the peripartum postpartum cardiomyopathy can be used. Before that trial was there is no because of excretion in the male, but some trial is going on that after the delivery you treat your patient like dilated cardiomyopathy to improve outcome of this mother. This depends on and living on your discretion and discussion. So I think there is a time constraint. So I will leave here. Thank you, and leaving some time for discussion because we know here our seniors is sitting. So thank you. This all from my side, and welcome for any comments and questions.
Yes, thank you, sir. That was a wonderful talk, especially on this topic because there are a lot of confusion to manage this patient. When it comes to management of heart failure in pregnancy, usually we talk about two pillars of management in heart failure. Beta blockers are the MRA and SGLT2 inhibitors. But when it comes to pregnancy, one of the beta blockers are the drugs which can be used. All other drugs can't be used. And the etiology of heart failure in pregnancy is very important. At times, it is idiopathic, that is part of we can't see. But there are some specific reasons which lead to heart failure in pregnancy. My wife is a specialist. Spontaneous pulmonary dissection, they are common in pregnancy, and stress-induced cardiomyopathy, these all are very common in pregnancy. So that was a wonderful talk. Thank you, sir.
Thank you, Dr. I'm so sorry for the presentation. Thank you. Now,
Dr. A.N. Rai sir is here. Can we give him mic, Dr. A.N. Rai sir?
yes,
Dr. Saad Ansari, your talk was excellent. And actually, we wanted your physical presence. We had very hard warm welcome at Lucknow during the UP chapter inauguration.
Thank you, sir.
I really thank you for creating the UP chapter. You are the
Thank you, sir. Thank you, sir. Thank you. Yesterday we was in Indian School of Hypertension with Neil Polter. That's why I was not able to come. So definitely next time I will be there with you, sir. Yeah.
Okay. Thank you. Thank you.
Thank you, sir.
From the audience.
Yeah.
From the audience.
No, sir.
No. So once again, we thank Dr. Saad Ansari.
Thank you, sir. Sabko pranam mera. Sare panelists.
Thank you. The next speaker is Dr. Nishant Kumar Abhishek from Patna. The topic is heart failure with reduced ejection fraction. Request the chairperson to introduce the speaker.
Heart failure is very common because it's most commonly after heart attack. And Dr. Shantam Abhishek is a university and yes, in cardiology. He has big hospital, and he has any conference at West CSI 2019 goal and active participation of the various national cardiology platforms in India, like CSI and Professor. You the presentation of Dr. Nishant.
Good morning, good morning, and audience. A lot of this that I have covered in my senior
consulted on various aspects of heart failure. So nothing much left actually. And he insisted that Nishant so I think due to the kind of life that he that no matter on root level, and goal life. And if you actually deal in cases of heart failure rather than going deep and digging in the presentations and the data, because the data is coming and the data is so apt, the data is so brilliant over the past 3 years that there has been a paradigm shift over the treatment of the way we are treating heart failure these days. So let's move on to the presentation. This is just a brief introduction or the framework of how to deal with heart failure with reduced ejection fraction. My first line is quantity. Important part. The most important part suspicion is heart failure shortness of breath or apnea and edema. Any presentation is possible, like jaundice, loss of appetite, abdominal bloating, chest pain, syncope, cognitive decline, arrhythmia, and potentially directly as cardiac arrest. Low threshold for advising ECG, chest X-ray in symptomatic patient, more in high-risk patient, as we already have mentioned, like hypertension, diabetes, old age, should be done. Early stabilization is also as important as referred to higher center. IV fluid first should be avoided at any point of treatment in any city that is possible, and diagnosing a case of shortness of breath, except other causes of shortness of breath are strongly clinically suspected. And following the 4 pillars of heart failure management and information about further possible treatment appears to be the most judicious approach at this point of time. Now, the few clinical variants which I have encountered in the past 2 years of my clinical practice, which is quite young to be honest. An 18-year-old boy presented to medical ER, history of shortness of breath over the last 7 days, progressing to NYH4. He was stabilized in CCU. His medical history was suggestive of rheumatic fever in childhood. Echo revealed moderate to severe aortic regurgitation, moderate mitral regurgitation with an LVEF of 25 to 30%. ECG had prolonged PR with raised ESR. X-ray was suggestive of pulmonary edema. He was treated with steroids and heart failure was managed with GDM. Patient improved and is now doing good in follow-up with mild residual AR with normal LV function. The learning point being that the patient was young, still suffered heart failure because he had an episode of rheumatic fever, and the most likely the current episode was a recurrence of rheumatic fever with persistent carditis causing the symptom. A 43-year-old IT professional presented in the OPD with history of undiagnosed cough more than nocturnal for 6 months, taking multiple prescriptions for the same, leg swelling for 15 days, and shortness of breath for 2 days. Non-hypertensive, non-diabetic. ECG and echo revealed severe LV dysfunction. CAT was normal. History of alcohol intake right from his teens was present. Patient was put on GGMT. Strict avoidance of alcohol was told to him, and he is doing good on regular follow-up. A 50-year-old long-standing diabetes patient presented to the ER with complaints of nausea, vomiting, and jaundice. Liver enzymes were in the range of 2,000 plus. Evaluation from the gastro side was not conclusive for jaundice. As I'm working predominantly in the gastro hospital, so this case was actually interesting. Evaluation from the gastro side was not conclusive for jaundice. A cardiac consultation was plainly taken for sinus tachycardia ECG and cardiomegaly on X-ray. His echo revealed severe LVD of 15 to 20% with dilated IVC with no other causes causing this symptoms. Troponin was negative, ENP was increased. So the patient was managed as a case of ADHF. So he never complained of shortness of breath ever in his life or in his hospital admission. So it's a plain case of congestive hepatitis with IV diuretics and GDM. Patient improved over the course of hospital stay and CAD later on revealed non-critical CAD. Patient is doing good on follow-up. A 62-year-old male diabetic and a known case of heart disease with decreased pumping was not improving well on GDMP, leading to frequent hospitalization. His echo was reviewed, which earlier showed mild to moderate AS with some LV dysfunction, which was suggestive of reviewing that echo. His echo was reviewed, which was suggestive of low flow, low gradient, severe aortic stenosis. Being a motivated patient and the earlier improvement that he felt from heart failure treatment, he actually went ahead for further treatment and was referred for a high-risk AVR. The angio revealed critical left main plus triple vessel disease. So he underwent the AVR plus CABD and post-surgery is still doing good on GDMP, and that event has been around 3 months from today. So just to outline what can be the presentation in the clinical scenario, we have read with things like stages of heart failure at stage A, the at risk for heart failure, patients with hypertension, cardiovascular disease, diabetes, obesity, exposure to cardiotoxic agents, genetic variants or cardiomyopathy, or family history of cardiomyopathy. Then comes the pre-heart failure stage B. Patients without current or previous symptoms or signs of heart failure, but evidence of one of the following, that is structural heart disease, increased blood pressures or risk factors or increased uric peptides levels or cardiac troponins in the absence of any competing diagnosis. Then comes the most common state that we clinically encounter, that is the symptomatic heart failure, that is patients with current or previous symptoms or signs of heart failure. And then the last stage, that is stage D, that is advanced heart failure with marked heart failure symptoms that interfere with daily life and require hospitalization despite attempts to optimize GDM. The stage 3 is called further as Sir actually knows, is the trajectory of stage 3 heart failure, which is new onset, resolution of persistent heart failure, and worsening heart failure. Then the basic diagnostic algorithm for heart failure with decreased ejection fraction or the basic classification. The assessment is sufficient on plain clinical history and physical examination. Important markers on ECG like left bundle branch block, high vesicular block, LVH with strain patterns, atrial fibrillation, complete heart block. These are the ECG patterns which we can get with patients of DCM. With an atrial peptide to substantiate and thoracic echocardiography to stamp heart diagnosis. And additional testing is only required if necessary. The heart failure diagnosis is confirmed. The determination of cause classification of course gives a good follow and the current admission. Evaluation of discriminating factors is very important. Treatment should be initiated and serial heart failure assessment should be done. The classification that followed is that we have discussed it time and again: reduced ejection fraction, mid-range ejection fraction. We have this reduced ejection fraction less than 40%, and in patients who have earlier reduced ejection fraction, but later have presented with the ejection fraction, the new classification of improved ejection fraction. The classification of improved ejection fraction is only important, leading to the fact that we need to pursue treatment in that case also. Mid-range ejection fraction is LVEF 41 to 49%, and preserved ejection fraction is LVEF 50 greater than 50%. Before going further, I would like to actually point out a very important point for HSPEF, that apart from the clinical diagnosis and whatever we are seeing with the patient, the most important thing is that a good echocardiography can only lead to HSPEF. A reduced EF is easy to diagnose, but HSPEF, a high degree of clinical suspicion with high volume echocardiography, low to free diagnosis of HSPEF. Now, these are the common causes of heart failure, the risk factors being the most population density, very frequently found, hypertension, obesity, pre-diabetes, and atherosclerotic cardiovascular disease. The most common being ischemic heart disease. Every 4 out of 5 patients is like coming out of CAD and leading into heart failure. And other non-ischemic causes, as we know, chemotherapy, cardiotoxic medication, rheumatological, autoimmune, metabolic disease, heart that is tachycardia, all tachycardia mediated. Are we facing as a cause of heart failure should also be pointed in patients of clinically based patients in which single chamber were faced or even two chamber were faced. Sometimes after 10 to 15 years, they do develop heart failure. That has actually come down and making the events of bundle spacing and conduction system facing more into the current scenario of intervention cardiology. Then hypertension, infiltrative cardiac disease, myocarditis. Initial serial evaluation, biomarkers, class 1 recommendation, no doubt about that, in patients with dyspnea to rule out heart failure, in patients hospitalized for heart failures as well as the trajectory in the heart they are getting the serial levels of biomarkers in patients at risk for heart failure that will come up as a community screening tool, not common in our part of the world, but soon we never rule out heart failure. And in patients that are running heart failure, we need to have BNP level measurements for risk stratification. Elevations of BNP has been like increased anemia, renal failure, pneumonia, obstructive sleep apnea, and PA. The basic serial evaluation class 1 recommendation of chest X-ray in a new onset heart failure, decompensated heart failure, to be found other pulmonary causes that can contribute to the patient. Transthoracic echo class 1 recommendation. Then if transthoracic echocardiography not informative, then cardiac CT, CMR, or nuclear imaging should be dealt with. Ischemia evaluation is a class 2 indication, and in patients with ischemia and CAD, class 2 recommendation is called revascularization. And in class 3, that is also important in patients to actually see the effect of patients because the echo will not improve very soon. It takes a period of time, 6 months to 1 year. Echo can be taken, but not in the very close scenario. Recommendations are access for heart failure, the common elements that should be treated with glycemic, hypertension should be treated, diabetes should be treated, CVD, cardiotoxic agents, patients should be screened for genetic cardiomyopathy. Increase heart failure of heart then we can early initiation of treatment with ARBs, beta blockers, ICT in patients of decreased LVEF survival and greater than 40 days post myocardial should be class 1 recommendations. Reduced ejection fraction in class C and D, the established diagnosis of reduced ejection fraction, all the 4 pillars as repeatedly pointed out, that the RB, beta blockers, MRA, SGLT2 inhibitors, and diuretics as needed to remove the congestion should be the standard of practice. We should be, in the next step, we should be titrating the target as followed. And the titration of is also very important. The point being that we should be initiating with the lower dose. In common practice, like if the dose is 50 BD for army, we are going ahead with half of 50. That is also not wrong, and we should be titrating it further because any cardiac drug should be initiated at the smallest possible dose, but the titration should always be kept in mind. That if the patient has improved
In environment, subset of population, we can go for other treatment. Now, the interventional treatments that are covered in step 4, that is ICD or CRTD, according to the patient profile. And finally, if the patient is not responding to all these treatments, then offers should be given for left ventricular assist device and higher therapies like cardiac transplantation. Additional medical therapies that after optimizing GDMP, these are the class of recommendations with these drugs, ivabradine, that is 2A, very super, that has come out very recently, that has 2B, goxin, UFA, and potassium binders in case of increased potassium in patients. Ivabradine, I feel like it will sooner or later come up in class 1 recommendation. Now, coming up with the interventional that have a special place in patients of reduced ejection fraction, because in patients of observed ejection fraction, further interventions are quite less, but in case of reduced ejection fraction, there is a battery of interventions that can be delivered and can give mortality as well as morbidity benefit. The CRT recommendation being heart failure on GDMP more than 3 months and 40 days after MI. If the survival is more than 1 year, then we should be going ahead with the interventional treatment. And these are the strength of recommendations. In frank LVBV with greater than 150 millisecond, this is class 1 indication. Non-LVBV greater than 150 millisecond. LVBV with a lesser duration of 120 to 149 milliseconds. Have other recommendations. Special circumstances in which patients with chronic AF where RP pacing is frequent or anticipated should be going for a CRT. In patients of normal sinus rhythm, in which RP pacing is frequent or anticipated, still like a patient of CHP and complete CHP with a background LVBB or CHP with complete pacing requirement, should ideally be going for a CRT and not plain pacing. Evaluate LVEF in case of 36 to 50% high degree of complete heart block to indication. In case of normal functions and bradycardia, for plain pacemaker. Additional device therapies after optimizing GDMP with suitable coronary anatomy, surgical revascularization. In NYHA 2 to 3 severe secondary MR after optimizing with the GDMP, we can go ahead with the transcatheter S2H mitral valve repair. That's a class 2A recommendation. This is again the talking about the mitral regurgitation that need to be tackled with reduced ejection fraction. In cases of coronary artery disease undergoing CABG, can be dealt with the same surgery, MB surgery. But in case of greater EF is normal, the surgery is the given choice. But if the LVEF is less and on patient is persistent symptomatic and on optimal GDMP, then mitral anatomy is preferable. Transcatheter treatment has taken over the surgical part in those subset of patients with a strength of recommendation 2A over 2B, that is mitral valve surgery. These are the recommendations for specialty referrals, continuous need of intravenous iron drops, decreased in-organ dysfunction, multiple defibrillator shock, more than one hospitalization, edema despite escalating diuretics, continuous low less systolic BP. These are the indication of mechanical support devices. In select patients with advanced reduced ejection fraction with NYHA class 4 symptoms who are deemed to be dependent on continuous intravenous iron drops for temporary MCS, durable LVAD implantation is effective to prove functional status. Cardiac transplantation of the mean adult survival is greater than 6 years versus less than 2 years for patients with stage D heart failure without advanced therapy. I have just 2 minutes to complete the slides. Patient hospitalized with decompensated heart failure have dealt with it again, that what can be the precipitating factor, most commonly congestion, discontinuation of drugs, fever. Simple causes can be arrhythmias, can be simple causations of decompensation. Monitoring and giving the standard decongestion strategy with IV diuretics, combination of diuretics. Post-discharge follow-up is very important with cases of heart failure. They should be kept motivated. They should be taking a exercise protocol. These things we have dealt with in the previous slides. AF management is important in heart failure. Rhythm or rate should be given a chance for atrial fibrillation ablation. That is a 2A recommendation. Thank you. And I'd like to say that I'm trying to maintain a continuous supply by indenting SGLT2 inhibitors as well as ivabradine, all those 4 pillars of drug in my parent place when I'm working, that is ESMCH beta. So if there are any patients motivated to be living long with heart failure, kindly refer to us. Those drugs are, the cost is taken out of the picture. Thank you.
Thank you, Dr. Nishant. Any question from the audience?
I request to show me the slide of that case, a 10-year-old boy case.
Yes, sir.
That's the first slide.
First slide almost.
Slide breaker. Slide breaker. Second slide. Second or third slide.
So, gentlemen, we are running short of time.
Okay, sir.
Thank you very much.
Okay.
Thank you, Nishan.
Thank you.
And now I request Dr. the moment to
Questions are very fast on me. And I will now request Dr. Shansar sir, who is the chairperson for the particular session. Now, only other chairperson, speaker, Dr. Nishant Kumar Abhishek from Patna, and let's do a huge round of applause for Nishant sir. It's very, very enriching presentation that he delivered over here. I would request all the chairpersons to kindly fill the stage and honor our speaker, Dr. Nishant Kumar Abhishek sir. एक बार शानदार ताली से अब आप देख पा रहे हैं डॉक्टर निशांत कुमार अभिषेक जी को सम्मानित किया जा रहा है हमारे माननीय चेयरपर्सन की ओर से और हमें अनुरोध कि हमारे बीच तीन राय जो कि आज के सेशन के बाद के परिचय कर रहे हैं तो कृपया करके हमारे दूसरे स्पीकर डॉक्टर उन्हें सम्मानित करें एक बार really amazing eloquent speakers. And I know you guys are not being a doctor and see chairperson for the particular session. Dr. Ian Rai, एक बार से और आप देख पा रहे हैं हमारे माननीय मॉडरेटर हमारे पर माननीय चेयरपर्सन डॉक्टर ए राय सर को सम्मानित कर रहे हैं और अनुरोध करेंगे कि हमारे बीच प्रोफेसर डॉक्टर बी के शर्मा सर को सम्मानित करें अपनी पैनल द्वारा शानदार तारीफ से इसी के साथ साथ हम अनुरोध करेंगे कि वो कृपया करके डॉक्टर शमशाद जी जो कि हमारे बीच एक माननीय चेयरपर्सन के रूप में उपस्थित हैं इस सत्र के दौरान उन्हें भी सम्मानित किया जाए और अब आप देख पा रहे हैं हमारे तमाम चेयरपर्सन से हमारे माननीय मॉडरेटर डॉक्टर आर चौधरी जी को सम्मानित करें वर्षांत कार्यक्रम से Let's have a huge round of applause for all of them for all the dignitaries on the stage. Thank you so much, Sri. So we are concluding this particular session, and we are all set to begin our next session, which is going to be a passion discussion. And in order to moderate this particular session, I will now have to call upon stage Dr. Ccdsicon, sir. I would like to call upon stage Dr. Ccdsicon, sir, as he already moderated for this panel discussion.
Good morning. I take pleasure to introduce the moderator of this panel discussion on regarders, Dr. Ccdsicon, sir. Sir is directly professor and head in the Department of Medicine in Netaji Suhas Medical College, Noida. Sir has served with the Gaya Medical College for long years. Chairman of the Ccdsicon, and I am brought under him last year. Sir has been chairman and secretary of API Gas Sector, chairman of the IMA, and since 2 days we are doing him active in this conference and putting his academics at a various level. So I introduce this session to Dr. Ccdsicon, sir, to proceed further.
All the panelists of this panel discussion. And the panelists are Dr. Kumar, Professor of Cardiology in the Institute of Medical Sciences. Please take your seat on the dais. Institute of Medical Sciences. Assistant Professor of Medicine, Rachi, my alma mater. Last but not least, Neeraj Kumar, physician, settled at Gaya. The medical college. After that, become busy practitioner and settled at Gaya. As we all know, dyslipidemia is important and risk factor for atherosclerotic cardiovascular disease. And we manage dyslipidemia according to international guidelines, which keep on changing from time to time. All of us have guidelines, which was produced by the Cholesterol Education Program in 2001. This guideline was revised in 2004, and according to revised ATP3 guidelines, dyslipidemia for about 10 years. Then came 2013 strong guideline College of Cardiology along with American Heart Association. And for certain reason, this guideline and considered Q and revised in 2018. Finally, by 2018, so many changes in guideline. Also, it had become very confusing. So far, the movement of dyslipidemia is concerned. Then came 2019 guideline proposed by the Society of Cardiology, the Atherosclerotic Society, the annual conference in Greece in 2019 September, which came in a small journal, especially European journal, in 2018. Shell, I can say, it's a very comprehensive guideline and well accepted. And for the last 3 years, we have been managing this epidemic. Almost every part of the world, we see the guideline. But the story does not stop here. In the last couple of years, a few new molecules have been included in our therapeutic epidemic. Yeah, by the so and the practicing physician, it is our scientific responsibility how to use these drugs effectively for management of this epidemic. As I said in the beginning, we have 4 panelists, so we have divided this panel discussion under 4 subgroups. In the first subgroup, we will have a brief introduction of European guideline. And for this section, the panelist will be Dr. Neeraj Kumar, who will discuss the details about this European guideline, especially certain aspect of it. Then we will discuss the established therapy of dyslipidemia, especially drugs which have been included in our European guideline, and for that guideline and the guideline. It will be discussed by Dr. Devendu Bhushan. And Dr. Gagan Munjal will discuss the emerging therapies, the newer drugs which have been included in the last 2 years. Finally, we will have a miscellaneous section where Dr. Neerav will be discussing the different aspects of dyslipidemia which are not covered in these guidelines, or at least which will be requiring a separate section. So with these few introductory words, I begin with the slides related to this. जरा सा इसको स्टार्ट कर दीजिए. हेलो. Panel discussion, Dr. Kekelani. तो वहीं से दिखाया जाएगा. वहीं पे बोलिए, स्टार्ट कर लें. देखना चाहिए. No. Talking about European guidelines, and according to European guideline, the first and the foremost responsibility of a treating physician is to do risk stratification. And this risk stratification is done in 3 stages, or you can say by 3 methods, different methods. The first one is chemical evaluation, and the second, clinical features, clinical conditions, on the basis of which we diagnose a patient as high risk or very high risk. These conditions are established atherosclerotic cardiovascular disease, hypercholesterolemia, CKD, diabetes, and lots of other risk factors. We will discuss in detail, or Dr. Neeraj will tell you in detail about these clinical features and how they decide whether a patient is high risk or very high risk. The second method is
by a computer generated formula, which is known as score. Systemic coronary risk estimation. It takes into consideration certain facts about the patient, certain data about the patient. We find in the computer and we get a score. If the score is more than 10, we call it very high risk. If the score is between 5 to 10, we call it high risk. If it is less than 5, another one, we call it moderate risk. And if it is less than 1, we call it low risk. And last one, now has taken into condition certain risk modifiers. These risk modifiers are conditions which enhances the risk category of the patient. Suppose a patient is low category, but if its risk modifiers are present, it should be considered as moderate category patient. These risk modifiers are lipoprotein A, lipoprotein B, lipoprotein diabetic dyslipidemia, especially high triglyceride, evidence of atherosclerosis on non-invasive investigations, and family history of premature coronary disease. So on these basis, we decide whether a patient is low risk, moderate risk, high risk, or very high risk. And as seen in this slide, the patients are classified into 4 categories: low risk, moderate risk, high risk, and very high risk. And for the treatment of these patients. For low category, it is 116 milligram per deciliter. For moderate, 100 or 70, and for high, it is 55 milligram per deciliter. Here I would like to mention one more thing. When the history of coronary artery disease within 2 years, cholesterol is concerned. All these things will be discussed by our panelist, Dr. Neeraj. I'm just trying to give you a direction. And finally, the million-dollar question is how to achieve this goals. And these goals are achieved on the basis of 3 modalities. Number 1, lifestyle modification. Number 2, lifestyle modification followed by lipid-lowering drug. And number 3, lifestyle modification along with lipid-lowering drug right from the beginning. Of course, this slide is a bit clumsy, but one thing is very clear that at every stage of management of dyslipidemia, at every stage of prevention of atherosclerotic cardiovascular disease, lifestyle modification is very, very important. And only after lifestyle modification comes drugs and other factors. So, this into the slides, I include now Dr. Neeraj, our first panelist, to come into the picture. You can use the mic from there, Dr. Neeraj, and let us know the practitioner as a physician what is your opinion about PC certification, how important it is, and what is the importance of different eligible goals for different category of patients, and how do we manage this issue. Lifestyle modification, something which we talk every day, but we do not practice in our practice, clinical practice. So, Dr. Neeraj, now it's time for you. You have 5 to 10 minutes time. I will request you to finish by 6-7 minutes so that we can have some questions also in 10 minutes.
Yes. Thank you, Dr. Lohani, sir. Sir has already introduced the topic. I will start from the very basic that managing the dyslipidemia is not same for all the patient. The very common proverb is that not the same shoe fits all fit. Here it's very true in case of dyslipidemia. So whenever we will start from very basic, then why we do risk stratification? We do risk stratification so that we can avoid under treatment or over treatment. Some patients are being under treated, some are over treated. So we stratify the patients of dyslipidemia in low risk, moderate risk, high risk, and very high risk. According to the European Society of Cardiology, we have 4 classes of different risk. So before going to that risk stratification, there is some scoring charts. So I will briefly elaborate the scoring chart. That is for whom this scoring chart is. This is scoring chart is not for the patients who are already in very high risk or high risk. These scoring chart are for screening of the general population. like the 40-year and above male patient, 50-year and above female patients. There are many risk factors present in them, but they are not easily identified, and we often miss the coronary risk factor among them. So this is a score chart, systemic coronary risk estimation chart, where 5 variables are used, that is age, sex, smoking status, then total cholesterol, and the systolic blood pressure. So different points are given according to all these 5 parameters. This is cumbersome as we see, but nowadays the app is available in our mobile, so we can easily calculate. So whenever a patient, young patient with his lipid profile report come to our clinic, and we have to decide, he says that Dr. Sahab, mera cholesterol gadbad ho gaya, humko dawa de dijiye. So we have to decide that whether he needs the treatment or he doesn't need the treatment. So this is the score chart. This is not for very high or high risk patient. This score chart is for general population who doesn't come in that high risk group. So here is a very interesting concept of risk age. So, for example, if a young male, 40-year male comes to us, so he is a smoker who has high blood pressure, who has high total cholesterol, and say, for example, his point is 4, he gets 4 points. So, 4 point is same for the 65-year male who is non-smoker, whose cholesterol is normal, whose BP is normal. So, this risk age concept is that 40-year male has got same risk age at 65-year male. So it's used to convince him that if you modify your risk factor, otherwise you have the same chances of getting myocardial infarction or stroke as a 65-year-old male. So after this scoring system, now we will go in the 4 classes of risk factors. The very high risk factor, moderate risk factor, and low risk factor. Who are the very high risk factor? Very high risk factor are documented ASCVD disease like stroke, MI, post-CABG, post-PCI, TIA, peripheral vascular disease. They are very high risk from very beginning, or even in coronary angiography or CT angiography, if there are significant plaques, they are very high risk person. So now diabetic patients, some diabetic patients are very high risk patients. For example, those who have got target organ damage like retinopathy, neuropathy, and nephropathy, they are very high risk patients. Then diabetes of long standing more than 20 years, or diabetes with some other major risk factors like smoking, raised blood pressure. So they are very high risk patient. Another patient are very high risk patient are CKD patient with eGFR less than 30. Then from this score chart, if the person gets more than 10% chances, that person is also very high risk person. So these very high risk persons are on the top of the iceberg. So what is the target of LDL in them? The target is 50% reduction from the baseline or less than 55. Remember, this is less than 55. LDL target is less than 55 for this very high risk group. Then comes the high risk group. Who are the high risk group? The high risk group are even the diabetic patients who don't have the organ damage, who don't have target organ damage, but they have got long duration of diabetes, more than 10 years, or some additional risk factors. In high risk group, some people with significant single risk factor like very high total cholesterol, more than 300, very high cholesterol, more than 200, and very high blood pressure, more than 180, 110. Then CKD patient, eGFR 30 to 60, and the score is 5 to 10. So again, these are the classes of high risk, and the target is again 50% from the baseline. LDL target is less than 70. This is less than 70. Again, there is a third group, that is moderate risk. Moderate risk are again diabetic patients who are young, like 35-year-old type 1, 50-year-old type 2, and the score is 1 to 5. These are moderate risk, and then low risk, the score is less than 1. So we have got 4 risk, and one take-home message I would like to give you, that all our diabetic patients, either they are moderate risk, or they are high risk, or they are very high risk. So always we have to target our LDL goal, keeping in mind that minimum LDL for diabetic, even at moderate risk, is less than 100, and even if other risk factors are then less than 70 or less than 55. So this is the risk stratification and the LDL goals. So there are some risk modifiers also. So risk modifiers are, for example, this classification is for European countries. So this, if we are coming from the Indian group, then there are some modifiers like socioeconomic deprivation, psychiatric illness, LVH, AF, NAS, obstructive sleep apnea, all these are modifiers. These modifiers basically upgrade the risk profile. If the patient is in moderate risk and there is risk modifier, then he will be fit in the upper risk. So, in this way, I have explained about the risk stratification, 4 risk and the 4 goal. So, 4 goals of LDL, we have targeted the LDL. Now, how to achieve this target? We have got the very basic thing is lifestyle modification. Then we have the drugs. So, about lifestyle modification, from very beginning, we are teaching our patients diet and exercise. Very few important topics I will tell you that regarding the diet. In diet, we have the fat, we have the carbohydrate. So, in fact, we should totally avoid the saturated and trans fat, and saturated fat should be less than 10%. Regarding the calories, the approximately 300 to 500 kilocalorie deficit should be advised to the patient. And coming on to the weight reduction, they should be asked to motivated that even 10 kg of weight reduction leads to lowering of LDL cholesterol by approximately 8 milligram per deciliter and elevation of SDL by 4 milligram per deciliter. So how weight reduction is important? By that, with weight reduction, we should, with diet modification, weight reduction and physical activity, this is the baseline. Then we should advise them people to completely stop smoking and alcohol. And if the lifestyle modification doesn't work, then we have to go to the drugs that our other panelists will discuss. Thank you.
Thank you, Dr. Neeraj, for elaborating all the introductory slides of European guidelines. One thing is very important, which you have pointed out, that this score system is not necessary for patients who has got clinical conditions associated with dyslipidemia. So, if we do a score system, it's good. Even if we don't do it, if we consider the different clinical criteria, we can decide which patient is high risk, which patient is very high risk. And the biggest example is diabetes.
Yes.
In the past, we did not take diabetes very seriously. In ATP3 guidelines said that it is risk equivalent to coronary artery disease. Now they have classified diabetes under 3 categories. It could be very high risk, it could be high risk, and it could be moderate risk, depending upon whether it is more than 20 years older diabetes with target organ damage, or more than 10 years with other risk factor, or less than 10 years without risk factor. So, as a clinician, our aim is to decide at what stage of diabetes the patient is having dyslipidemia, or lipid levels should be managed accordingly. And regarding lifestyle modification, you have pointed out the salient features, but in guidelines, they have very clearly said that there are certain targets which we should achieve, like the saturated fat, yes, no. Then sufficient fruits and vegetables and fiber should be taken, we all know. They have very categorically said that BMI should be between 20 and 25. They have also mentioned about the waist circumference, and for Indian patients, it is different from the European guideline, 90 for the male and 80 for the female. Yes. So we should stick to these guidelines also. Even blood sugar HbA1c is important. It should be less than glycosylated should be less than 7. And according to American guideline, it is less than 6.5. Likewise, blood pressure, it should be 140 by 90, less than that according to European guideline, but in American guideline, it should be 130 by 85. So we have to take care of all these things, then only, and this is the era of treat to target. We must fix the target, and we must try to assess in every visit that whether we are near the target or not, and what else we should do. So thank you very much, Dr. Neeraj. And now we go on to the next part of it, that is lipid lowering drugs. And according to European guidelines, and for that reason, even in American guideline in 2018, nowadays they have included 3 drugs for the treatment of dyslipidemia, especially LDL cholesterol. Statin is the primary drug, we all know. It is the drug of choice for management of dyslipidemia. Since the beginning of this century, exactly in ATP3 guideline was the first major effort to establish this drug as the drug of first choice in the management of dyslipidemia. If dyslipidemia is not managed with statin alone, then we have the option to add another drug, and this second drug is ezetimibe. And if both these combinations are not enough, we have got a very powerful drug in our armamentarium for last 5 to 7 years, and that is PCSK9 inhibitors. If I remember correctly, it was approved by FDA in 2015, so it is about 7-8 years now. So either statin alone, or statin with ezetimibe, or statin with ezetimibe with PCSK9 inhibitors. And they have given a data that moderate intensity statin reduces LDL cholesterol between 30 to 50%, high risk above 50%, high risk statin plus ezetimibe 65%, PCSK9 alone 60%, PCSK9 with moderate intensity statin 75%, and PCSK9 inhibitors plus high intensity statin plus ezetimibe 85%. So in nutshell, we can say that now we have enough drug to reduce LDL cholesterol, even up to 85% reduction we can achieve with these drugs either alone or in combination. And accordingly, we are supposed to use it. And definitely it depends upon the baseline LDL level of the patient, the category of the patient, and the baseline LDL level. And accordingly, we can use these weapons. But then there is also a fact that in majority of our very high-risk patient and high-risk patient, we do not achieve the target. Either we do not bother to add ezetimibe into it, or we do not use high-intensity statin, or we cannot afford PCSK9 inhibitors. Whatever the reason may be, 2 new drugs have been included in our therapeutic armamentarium in last 3 years. Since 2020. 2 drugs have been included. One is bempedoic acid and second one is inclisiran. And from this chart, this is a very beautiful chart because it simply classified the mechanism of action of these drugs. Statin, we all know, inhibits synthesis of cholesterol in the liver by inhibiting an enzyme, coenzyme A reductase. Bempedoic acid also acts in a similar manner, but it works a bit earlier and it involves another enzyme. But both drugs have got similar mechanism of action. It inhibits synthesis of cholesterol in the liver. Ezetimibe, we all know, it delays the absorption of cholesterol from the gut. It is also there since 2004, if I remember correctly. And on and off we use it, but till date we have not used it for its full, its utility has not been taken care of accordingly. And the newer drug, PCSK9 inhibitor, we all know, it facilitates the excretion of LDL cholesterol from blood by upgrading the LDL receptors. It is a monoclonal antibody. Nowadays, it is called PCSK9 monoclonal antibody. And a newer drug has been introduced, inclisiran, which is nowadays called the true PCSK9 inhibitor because it inhibits the formation of PCSK9 by inhibiting the messenger RNA responsible for it. So now we have got 2 monoclonal antibodies. One is 2 monoclonal inhibitors, PCSK9 inhibitors. One is monoclonal antibody, traditionally, which we used to call monoclonal, antibody. Nowadays, previously it was called PCSK9 inhibitor. And nowadays, inclisiran is also included in the category of PCSK9. So altogether, we have 5 drugs and we use it according to need. Statin, we all know, we have been using it for more than 2 decades. We all have used statin. We all are well aware of it. If anything new is there or any clue is to be given, our next panelist will give us. Just 2 things I would like to mention here. For last 5 years or 7 years, especially since this American guideline 2014 guideline came, we have been using the term high intensity and moderate intensity statin. And it is very clearly written that by high intensity statin, we mean rosuvastatin in the dose of 20 to 40 milligram per day and atorvastatin 40 to 80 milligram per day. So there are only two statin which can be considered as high intensity statin, and every other statin is moderate intensity statin. So when we talk of high intensity statin, either we should use rosuvastatin in 20 to 40 milligram or atorvastatin 40 to 80 milligram. Another important thing about a statin, we should know how often we should go for lipid profile. And according to different randomized clinical trials and its outcome, it has been found that we should do it one at the baseline, second after 1 to 3 months, and thereafter every 3 to 12 months. In clinical practice, what I do, I take a baseline, I repeat it maximum within 3 months. Or if patient is very curious and very anxious and patient can afford, we can do it after 1 month also. And after that, I do it every 6 months. So as per guidelines also, it should be done every 3 to 12 months. So we should know about it. Then comes the newer drugs, ezetimibe. We all know, we have been using it. It is available at 10 milligram tablet. It is a safe drug and it gives you a reduction of about 24%. Evolocumab and alirocumab are PCSK9 inhibitors. We all know it is given as injectables, subcutaneous injection, monthly injection or fortnightly injection. It is a very, very costly drug. But as I said, it can give you about 60% reduction on its own. Bempedoic acid is the new drug. 10 milligram tablet gives you about 30 to 35% reduction. And it should also be used as add-on drug. And inclisiran is another drug which can give you more than 50% reduction. It should be used as subcutaneous injection, but frequency of injection is less. So, in nutshell, we have 5 drugs. 3 drugs we can call established therapy: statin, ezetimibe, and PCSK9 inhibitors. And 2 drugs can be called emerging therapy, that is bempedoic acid and inclisiran. And as a clinician, our responsibility is to use these drugs in different combination if and when required. Now, I would like to include our 2 panelists in this part. The first panelist, Dr. Devendra Bhushan, will discuss the established therapy, that is statin plus minus ezetimibe plus minus PCSK9 inhibitors in the management of dyslipidemia. And the second panelist, Dr. Gagan Gunjan, will discuss the newer drug, bempedoic acid and inclisiran, along with how to use it along with statin in the management. So one by one, Dr. Devendra, please, it's your time.
Thank you, sir. So first of all, regarding the lipid lowering drug, those are the gold standard drugs like statins and ezetimibe. So practically speaking, when we are treating dyslipidemia, only these 2 drugs come into the play. Yes, it is a recent advancement that we are talking about the high intensity statin therapy, and we are giving it especially in cases of MI, recent MI, stroke patients, very high risk cardiovascular risk patients. But still, I doubt that, as those patients are also receiving various therapies, diabetic patient receiving metformin, they are receiving dual antiplatelets. So chances of adverse effect is more. Even when the person is using high intensity statin, the chances of developing gastritis, hepatitis is even more. So it is important to look down the LDL, yes, and it is important to check it 3 monthly or 6 monthly. But how much it is come into the real life, I am not sure. I think my cardiologist colleague will better tell us. But yes, we are using the high intensity statins. About the ezetimibe is an older drug. It is around 15 to 20 years old. But the chances again, along with the using statins, ezetimibe, there is a high chance of developing hepatotoxicity. So when the ezetimibe came into the market, for around 5 to 10 years, it become a hot cake. But nowadays also the use of ezetimibe has decreased down. One word about the PCSK9 inhibitors. Yes, I don't know how many of us are using it. I tried to get the medicine in 2 or 3 patients, but I am failed to get it in my institute. So no real life experience with that medicine. But yes, it is a promising medicine. Even the other thing is more feasible, like LDL apheresis. Once we are searching about this PCSK9 inhibitors and we are not able to get it, then we talked about the apheresis team, our blood bank team, and they said it is quite possible to do a LDL apheresis to the patients. So at that patient, we didn't tried it, but it can be a feasible thing. I would like to hear from someone who has used PCSK9 inhibitors. They are promising, but yes, their availability and cost are the issues. So this is from my side, sir.
Well, it is well, but certain things I would like to know from you, Dr. Devendu, about about using high intensity statin. I'm very confident that most of us are not using high intensity statin. What could be the reason? Is it the risk of side effect, or patient cannot tolerate it? And if the side effect occurs, what should we do? What do you suggest?
No, sir. It is not so that we are not using it. We are using it. We are now, as per the guidelines, we tried our. We are following the guidelines and we are using the high intensity statins. But I can't say it is not a large chunk of patients which I am seeing. So I can't say percentage wise, but few of them has developed hepatitis. So I lower down the dose. That is
what do you do when the patient develop side effect, muscle related side effect, or
mostly hepatotoxicity, sir.
Hepatotoxicity. What do? You stop the drug or you reduce the dose?
You choose, if it is high, like if it is more than 3 to 5 times, then I stop for a few days and let the enzyme settle down to the little normal, about up to the 2 times, and then we can restart with them in a modest amount.
Modest. And at what stage do you think of adding ezetimibe to these patients? Okay, PCSK9 inhibitors were not available in India in the recent past, and even if it is available, it is very costly. There's no doubt about it. But what about ezetimibe? Why people are so hesitant about using this drug?
No, sir, I don't think so. Somebody is hesitant about it, but we can use it. But we have to be very careful about the hepatotoxicity. Otherwise, it is a wonderful drug. And if you talk about my practice, I have not seen hepatotoxicity with this combination therapy. But many of my colleagues has experienced it.
And do you really think that the hepatotoxicity is more when you use ezetimibe along with statin? It's statin alone and statin with ezetimibe. The risk of hepatotoxicity increases with
the data says that it increases. Yes,
it is increased.
Yes.
In that situation, what do you do? What is the substitute? Suppose cholesterol is high and the patient has developed hepatotoxicity.
So if the person develop hepatotoxicity on statin plus ezetimibe, then I would like to stop both the drugs at that moment, and then we will start statin alone in the modest dose.
And now I invite Dr. Gagan about why these 2 new drugs have been included in our therapeutic armamentarium. What was the reason? Was ezetimibe and PCSK9 inhibitors not enough to deliver the goods, or just it was developed out of curiosity? And okay, if it is developed now, what is the best way to utilize these 2 drugs in our clinical practice, as individual drug or as an add-on drug? So please.
Thank you, sir. Good afternoon, everyone. Just now we heard Dr. Devendu Bhushan speaking about the established drugs, statins, ezetimibe, and PCSK9 inhibitors. Now there are 2 questions that arises after using these drugs. What if we fail to achieve the target level of cholesterol? First. Second, what if there is statin toxicity? We all know statin remains the gold standard drug for treating dyslipidemia in spite of all new inventories. But in these 2 conditions, even if the target level is not achieved or we have statin toxicity after using it on a higher dose. So this was the basis for invention of new molecules. And surprisingly, we have two new molecules now, bempedoic acid and inclisiran. If we look back at the history of bempedoic acid, the inventor of this molecule, Mr. Roger, is the same person who invented atorvastatin long back. He got separated from Pfizer, and later on he came up with this molecule after 8 years of struggle. He started in 2012 and it got approval finally in 2020. So bempedoic acid is not a monotherapy or not as a startup therapy. It is always an add-on therapy to statins. This is clear fundamentally. If after using statins or ezetimibe we are unable to achieve, then we should think of adding on other drugs like bempedoic acid or inclisiran. So bempedoic acid basically acts by inhibiting ACL inhibitor, that is an upstream molecule in the HNT-CoA reductase pathway. So by inhibiting this, we have the basis of what is the basic main mechanism. Now this acts as de novo, that is a prodrug which gets activated in the liver itself. So there is no question of myalgia that happens with statins. The daily dose is 180 milligram OD. If it is used alone, it can achieve 25% reduction in the cholesterol. But if as add-on therapy to other drugs like statins or ezetimibe, there can be additional 15% lowering of lipid cholesterol. So the only molecule that is preventing us from using this drug in our country is cost effectiveness, and there are slight those adverse effects like hyperuricemia, gout, or tendon rupture, or in some cases reported cases of atrial fibrillation. But it is a promising drug if we can manage the cost effectiveness as an add-on therapy to statins. Now we come to the next molecule. Even bempedoic acid, there has been various trials like Clear Outcomes trial, Harmony trial, Serenity trial, Tranquility trial, all have proved its beneficial role in lowering down cholesterol. Cardiovascular effects trial are being studied and the result will be out in the next 1 to 2 years. If we move on to the next molecule, that is inclisiran, it is a PCSK9 inhibitor. So PCSK9 inhibitor acts monoclonal antibodies used to act extracellularly by inhibiting PCSK9 inhibitor, but this inclisiran acts intracellularly and inhibits the PCSK9 enzyme itself from its production. The molecule PCSK9 inhibitor used to be given usually within 15 days, that is twice a monthly, but inclisiran has the advantage of being used subcutaneously once, 0, and then after 90 days, and then 6 monthly, that is twice a year. So this is the advantage of using a inclisiran with a few doses of injections. Besides, it also gives us reduction of almost 50% cholesterol, which is very similar to PCSK9 inhibitor, slightly lower, but dosing frequency is making it popular. So we look forward to all those trials of inclisiran like Orion 10, 11, and 12 in the second phase trial, where approximately 3,457 patients were enrolled, and all of them have shown favorable outcome. So whether it be Clear Outcomes trial or Orion trials, both the trials have shown favorable outcome in lowering down the lipid cholesterol level as well as in patients when used with atherosclerotic cardiovascular established disease. So thank you, sir. This is from my side.
Thank you, Dr. Gagan. You have explained everything very nicely, but there are two questions for which I would like to have answer from your side. Nowadays, it is becoming a tendency either on the part of pharmaceutical companies or whatever the reason may be, that people are tempted to use bempedoic acid as a monotherapy. Everybody is saying that this is the substitute of statin in clinical practice. What is your opinion? Do you see the future of bempedoic acid as monotherapy in the treatment? No. Or whenever, what is the situation when we should consider this drug as monotherapy?
Bempedoic acid is still not to be used as monotherapy. First, I already made it clear. First, statin remains the gold standard. After using statin, if we are unable to use statin due to some reason like myotoxicity or anything for the adverse effect, then only bempedoic acid should be considered as a monotherapy. But if patient is able to tolerate statins and statins, there is no replacement to statins.
Second thing is, by and large, it is a safe drug, but uric acid is a problem with bempedoic acid. It is increased. It has been observed in different trials. So, should we stop it, or it is written in the literature that we should continue with bempedoic acid and we should add uricosuric agent also if the patient is suffering from hyperuricemia or what? So,
the incidence of hyperuricemia or tendon rupture is very less, even with bempedoic acid. But still, if we can lower down, the recommended dose is 180 milligram daily. But in such cases where we have the hyperuricemia or gout reports, we can either decrease the dose or we can continue with add-on therapy of uricosuric acids.
one thing which we did not discuss while discussing the lipid-loading drugs, there are two situations where we should use, either we should not use or we should use very cautiously. Statin in elderly population above 75 years of age, it is said that we should use it only when there is definite indication or if the patient is having high or very high risk category. In mild to moderate case, we should not use statin in elderly patient because the risk of side effect is a bit higher in elderly. And number two, nowadays in pregnancy for last 5 years or 6 or 7 years, since 2016, it has been absolutely contraindicated. It has become contraindicated in pregnancy. We will discuss issue this pregnancy related dyslipidemia in the end. But what about the treatment of dyslipidemia in elderly individuals? What do you suggest? What should we do?
Even in elderly populations, the new two drugs, bempedoic acid and inclisiran, are promising drugs. In cases of mild to moderate liver or renal failure, there is no contraindication to these new drugs. These drugs can be used safely. Only some literature says that in severe cases we should avoid. Even that research is going on, and we will have more research publications in the coming next 2 years. So there is no contraindication to these drugs in mild to moderate liver or renal failure.
Very good. And as such, till date, bempedoic acid is an add-on drug for statin. It should not be encouraged as a monotherapy. And the explanation, one explanation is very simple, which is related to commerce. Nobody will like to buy a Maruti 800 in the cost of Mercedes-Benz. 5 milligram of rosuvastatin or 10 milligram of atorvastatin cost 5 rupees, if I remember correctly. There are many companies, but one tablet of bempedoic acid costs you 20 to 25 rupees. So and reduction is less than 25% with bempedoic acid. So this much of reduction you can get even with moderate intensity statin. So there is no need to become very, advanced physician to use bempedoic acid as monotherapy. We should still stick to statin, and when required, we should not hesitate to use either ezetimibe or bempedoic acid. Both are tablet form. And if situation arises, we can have the services of two very good molecules. Number one is this PCSK9 inhibitors, and number two is inclisiran. So thank you, Dr. Gagan Gunjan. And now we come to the third section. And during this section, first of all, we are going to discuss, naturally for this last section, our panelist will be Dr. Nirav. During this section, first of all, we are going to discuss how to utilize these drugs in clinical practice. What we have been discussing for last half an hour. There should be a scheme. Naturally, these two drugs are not included in our guidelines till date. But in 24, we are expecting some guidelines where these drugs will be included. Then we will act accordingly. As on date, how to use these drugs? How to utilize these 5 drugs which we have in our armamentarium? And they have given an example. Naturally, I have taken it from a journal about the newer lipid-loading drugs. And message is very straightforward. Example they have given is that of acute coronary syndrome, because that is one situation where you need maximum reduction in LDL cholesterol. So a patient of acute coronary syndrome, suppose comes to your clinic or your hospital, he can come with 5 different situations. Either patient is not on lipid-lowering therapy. In that situation, our aim is to start lipid-lowering therapy, definitely high-intensity statin. So that is the first situation. Second, patient is already on statin, but not high-intensity statin. Then we should increase the dose and make it high intensity. This is the second situation. Third situation is patient is already on high intensity statin, still the LDL is above 70. LDL is not at goal. In this situation, first aim is to add ezetimibe. Even after ezetimibe, if the goal remains high, I mean the LDL remains high, then we have two options. If we need about 20% further reduction, we should add bempedoic acid. If we need about 30-40% further reduction, then we should use either PCSK9 inhibitors or inclisiran. So this is precisely this graph is all about. So at this stage, I will request Dr. Nirav to let us know, is it correct or we can have a different protocol in our clinical practice about using these 5 drugs? Dr. Nirav, please.
Good afternoon, sir. I think in real practice, in our clinical practice, reducing the cholesterol level is not very big deal. In Bihar, particularly in Bihar, LDL cholesterol is slightly raised. There is combined hypertriglyceridemia. Usually there is triglyceridemia as well as lipid LDL level is around 90 to 100. So usual, and because of the small size, maybe something related with gene, usually there is fall in LDL cholesterol level. So we should start in practice like we should start with giving them scoring is not possible in our clinic, and we do not follow our patient how much percentage there is fall of LDL cholesterol, whether it is 50% or 20% like that. So better to start with the seeing the original report, the basic report, how much is the LDL cholesterol, and we should certify the risk factor right side, because every scoring system is because of the age, smoking, diabetes. So we should score the risk factor. If risk factor is more, we should treat the patient, and we should follow those patients whether it is down or not. Definitely, we should have a clear idea regarding very high risk patient, moderate and low risk patient. And regarding the addition, in my practice, I found only 2 patients in which PCSK9 was required, and only 1 patient was able to afford it, because I am in poor hospital, maybe in Vedanta and other hospitals, they must be using more than that. So it is very rare to use PCSK9. Ideally, we should start with the statin, add ezetimibe. There is very good combination for reduction, and there is motility benefit also, because in IMPROVE trial there was motility benefit. So these 2 drugs, there is no doubt about that. The third addition, PCSK9 in our region, it is very difficult, because almost $500 is required for naphtha drug, which is available in Bihar. So that is the problem.
Thank you, Dr. Nero. Just 2 quick questions I would like to ask you. Number 1, nowadays, are we using this PCSK9 inhibitors in Patna?
Yeah.
Is it available?
My one patient is on PCSK.
Inclisiran is also available in Bihar, Patna? Inclisiran?
No, it is not available.
But PCSK9, evolocumab, we are using in Patna. Anyway, another question is a very old issue. In most of the cases of acute coronary syndrome, a statin which is advised is atorvastatin 80 milligram, high intensity atorvastatin. In all the recommendations, in all the trials, you will say atorvastatin, not rosuvastatin. So is there any logic behind using atorvastatin in acute cases? Or we can use atorva or rosuvastatin, anything?
I don't think there is head-on comparison between atorvastatin and rosuvastatin in any trial. And definitely with high dose rosuvastatin or atorvastatin, there is problem within 2 to 3 week patient complain that he is having vague type of pain, he is not feeling energy, he is getting down every time. So that is the problem with high intensity. All our angioplasty patient or high intensity patient, high intensity statin, and after 2 to 3 week or 4 week, we are bound to reduce it because of these complaints. This is very common in Bihar, in the small size patient.
If I remember correctly, somewhere I was reading in an article that when you need acute reduction in LDL level, say after acute myocardial infarction, atorvastatin is the choice. But if you need long-standing reduction in LDL cholesterol, rosuvastatin is more potent. It gives you 5 to 10% extra reduction in LDL. But immediate reduction, choice is atorvastatin. Do you agree with it?
I think that in most of the SKS patients, LDL is around 90 to 100, and after giving 40 milligram rosuva or atorva, it fall to 20 or 30 like that. Majority of cases there is huge fall.
So anything can be used, either atorva or rosuva.
And there is these logic are given by some conspiracy theory. I don't think there is. If there is no head in the trial, how
in most of the trial it is atorvastatin and written. That is why I ask you.
Yeah,
okay,
only one condition, sir. If there is renal failure, atorvastatin is better than rosuvastatin.
Homozygous familial hypercholesterolemia. We always talk about this condition, and it is considered as a condition for which there is no treatment. Nowadays, there are few drugs in the pipeline like mepromycin and lomitabide. Just in brief, can you let us know what is this condition, especially homozygous familial hypercholesterolemia, how to suspect it in clinical practice, and how to approach it? FRS, what Dr. Devendu was talking, is perhaps the only treatment till date for this condition. But nowadays, they say that with lomitabide or mepromycin, the chances of FRS is reduced to a great extent. So, can we have just expert opinion from you on this issue? Familiar hypercholesterolemia.
Yeah, in familiar hypercholesterolemia, there is very high level of cholesterol, maybe more than 500, and it is very rare, 1 in 14,000 or 60,000 like that, it is present. The suspicion is if there is premature coronary artery disease in family history, father or mother suffer before 55 or 60 years of age, if there is tendinous xanthoma in the patient or in the relative, if there is sudden death in the family, in all those conditions, we should suspect and we should confirm it by the DNA study also. So whether there is usually the PCSK9 gene, ApoB gene, and the LDL receptor gene, there is a mutation of that, and it is because homogeneous, the maximum patient died within 30 years of age. The maximum patient present within 12 to 20 years of age. So in this condition, only treatment available is the lipoprotein apheresis, which cost in Europe is around $2,500. In Europe, it is cost. So it's very expensive treatment. Treatment is available, but it is you can give the medical therapy. There may be some response, and the target for child is below 150. It should be below 150 for child. And for adult, it should be 50 to 70, depending on how much is the risk factor.
So in nutshell, if it is heterozygous familial hypercholesterolemia, to some extent the drugs are effective. But if it is homozygous, none of these drugs act, because the excretion of LDL, that mechanism, there is mutation in the gene, so there is no excretion, so none of the drug act. Fortunately, this mepromycin and lomitabide, these two drugs have been developed which act by different mechanism, and they have shown a lot of promise. Mepromycin is used as injectable, but it has got again the same problem. It causes hepatotoxicity and steatosis. So it has been withdrawn after approval by FDA. This lomitabide is another very promising drug. It is oral drug, and it causes about 30%, 25 to 30% reduction in LDL cholesterol in homozygous variety. And let us hope in future it will come in our clinical practice, and then the risk of FRS will be reduced. It won't be completely,
Sir, one small correction, sir. If it is homozygous hypercholesterolemia, if we are using ezetimibe, it will reduce, it will act like protein and intestine. So it is effective. It is effective, but the extent of effect is not same as other person. So you should use the medical therapy also, and you should use the lipoprotein apheresis also.
Now we come to another very important issue which you were talking about, everybody was talking, mixed dyslipidemia, dyslipidemia where LDL is high and triglyceride is also high. It's a very common problem in our clinical practice in Indian diabetic patients. How do you deal it? What drug is the choice nowadays?
So if the triglycerides are high along with the LDL, then yes, we can use statin plus fibrate product and derivatives. And yes, if the person is having a little bit of impaired glucose tolerance or diabetes, yes, we can add saroglitazar. Saroglitazar is a very good drug for controlling the triglyceride. I have used it in many patients. It is quite effective. The only side effect is its cost. So after say not that it is not that costly also, but after 3 to 6 months, patient says कि डॉक्टर साहब को ये सस्ता दवाई तो नहीं है. So that is the thing, but it reduces the triglyceride like anything. It reduces it.
As per the guideline, they say that if the triglyceride is between 150 to 500, we start treatment with statin. And even after treatment, if you find it high, then you add a drug specifically for this group. Nowadays, the choice is icosapent ethyl 2 into twice daily, 2 gram twice daily. In the past, we were using fibrates. The newer drugs, seroglitazar, can do the same work. So that is the approach. If triglyceride is less than 500, start treatment with statin, and after 1 or 3 months, if it is high, then add 2. Now we are coming to the last slide. We are running short of time. The last slide is dyslipidemia in pregnancy. And in one line, I convey the message. All lipid-lowering medications, aside from bile acid sequestrant and omega-3 fatty acid, should be stopped before conception or immediately when pregnancy occurs. This is a very unique information which we should know. None of the drugs which we were talking about can be used in pregnancy. There are only 2 drugs safe for cholesterol, bile acid sequestrant, cholestyramine, and for triglyceride, omega-3 fatty acids. Everything else is contraindicated according to guideline, according to different trials. So that is a very important message we should know. And I would like to conclude my talk here by quoting a very famous anecdote. Someone asked Buddha, what is poison? He replied, everything excess in life is poison. What Buddha said more than 2,500 years ago is very, very true even today, especially in context of atherosclerotic cardiovascular disease. We talk a lot about LDL cholesterol, but it is not only cholesterol which is bad. Excess of body weight is bad. Excess of blood sugar is bad. Excess of blood pressure is bad. Excess of smoking is bad. And excess of inactivity is bad. Smoking was always bad, and excess of alcohol is bad. That is precisely inter-heart study. So when we want to prevent atherosclerotic cardiovascular disease, we should take care of all the line modifiable risk factors. Yes, dyslipidemia is one of the most important modifiable risk factors. Thank you very much, all the 4 panelists, and thank you everybody for your patient hearing. I wish I had some questions from the audience, but we are getting repeated ring from the organizers. So I think we have tried to cover almost every practical aspect of dyslipidemia management. Thank you once again, and thank you organizers once again.
Thank you, sir. So please proceed to presentation.
Thank you so much, sir. And I would expect each one of you to manage for one of the managers. And I would now report I am going to coordinator or really reminder and not over the on our management for this particular discussion. I would recommend Dr. Rita Kumar, along with the DA to Dr. Rita Kumar, let us have a huge round of applause for our own family. Between our to have a very powerful and specifically for the discussion. श्री प्रमोद कुमार हमारे और अपने हमारे प्रमुखी जो it is truly a delight for all of us to have all of you. And thank you so much, for being on us. This is very happy. We are now sitting on the emergency office, but we have interaction. And now we are all set to head to our next session. It is going to be moderated by Dr. Neeraj Kumar somewhere of the department, and our opportunity in order to moderate this session. And we were also planning to develop a topic in the and I would now like to hand over the proceedings of this particular session to you and you.
Hello. Are you now? So we are running short of time. So very quickly, I would like to call upon the stage our chairpersons, Dr. Bhavesh from Begusarai. Kindly come on the stage, Dr. Bhavesh. And
I will like to inform all the speakers who are yet to deliver their lecture that they will have to bear with us. We have reduced the lecture delivery time by 5 minutes, so it will be favor to us if they finish within 15 minutes. Thank you.
Dr. Bhavesh from Begusarai, Dr. Virendra Kumar sir from Bhagalpur, and Dr. Sambhu Kumar from Begusarai. Kindly come on the stage. Then Dr. Ajit Kumar Sinha sir from Begusarai. All the 4 chairpersons, please kindly come on the stage. And as Dr. P.K. Singh sir informed, the time limit has come. 5 minutes has been cut from the talk time. So please, the speakers, bear with this. So only 15 minutes time is there. So I would like to hand over the mic to the chairpersons. Kindly proceed the session. Thank you.
First of all, good afternoon. It's already leading the session. So, as a first speaker, I'm glad to invite Dr. Sudhir Kumar to have a presentation on what is it? Dramatic manifestation of the diabetes. Dr. Sudhir Kumar sir from Patna. Good afternoon, everyone. Moderator, senior and my colleague. Today, I'm going to talk about one of the neglected aspects of the matters, that is the rheumatological manifestations. And increase mortality and morbidity by in the form of macrovascular and macrovascular complication. Diabetes, we all know, is a multi-system and a multi-organ dysfunction, which can lead to a lot of morbidity. And at current, the total prevalence is around 550 million, and by 2030, the total prevalence will increase by 2.5% of the total population. Now, depending upon the extent of control and dying organ damage, that may clinical and subclinical nature. Musculoskeletal manifestations are equally unrecognized and very
like unlike other conditions like nephropathy, neuropathy, and cardiovascular complications. Now that there are different causes of rheumatic manifestation. Persistent hyperglycemia is one of the common cause. Hyperinsulinemia in the cases of insulin resistance. Advanced glycosylated in products and inflammation is also the major cause of rheumatic manifestation. There are different classifications. In this classification, we have classified different rheumatic manifestation into 5 groups. The first group is syndromes of limited joint mobility. Limited joint mobility, which is consists of 4 parts. Number 1 is stiff hand syndrome. B is dependence contracture. C is trigger finger. D is frozen shoulder. Second one is directly related to bone health, that is osteoporosis. Third one is diffuse idiopathic skeletal hyperostosis or Forster's disease. Now, the fourth part is related to neuropathy. Among the neuropathies, the different manifestations are in the form of Charcot joint, very common, carpal tunnel syndrome, diabetic amyotrophy, a very uncommon condition, reflex sympathetic dystrophy, and the fifth one is direct muscular involvement, that is diabetic muscle infarction. Now, one by one, we will look for all the different conditions. Number 1 is diabetic keloarthropathy, that is stiff hand syndrome. It is characterized by the painless limitation of the mobility of the small joints of the hand, and prevalence is very high in type 2 diabetic mellitus. And hair sign and tabletop sign is very a common sign, which is now the case of stiff hand syndrome. This is the photograph of prayer sign. In prayer sign, normally when we keep our hand together, palm together in the prayer position, all the aspects of the palm get in contact with each other. While in case of stiff hand syndrome, only a few contacts are there, and most of the palm are separated from each other. Now, this also one first photograph of the prayer sign, and second one is about the tabletop sign. When we talk about the second condition, that is difference contracture, it is characterized by the thickening of the palmar fascia, causing a contracture in flexion of the affected finger. In individual with diabetic mellitus, it mainly affects the third and the fourth finger. In non-diabetic, the fourth and the fifth fingers are the most commonly involved. And the prevalence is very high in case of diabetes in comparison to non-diabetic. The diabetic duration, long-term poor control, and the presence of microvascular complications are the major deciding factors. The good glycemic control, physiotherapy, local steroid injection, local collagenase injection, and in refractory cases, surgery are the major treatment. Now, in this photograph, in the first one, we can see the nodules which is present in the palmar fascia, leading to slight contraction of the finger. In the second one, the band is there, which is very thick, leading to slight flexion of the finger. And in the third one, it is full flex position of the third, fourth, and the fifth finger. The trigger finger, also known as snoozing flexor tenosynovitis. It is a tendinous inflammation of the flexor feet that travel along the fibrous tunnel and causes the finger blocking in flexion and active extension failure. The classic presentation of popping and locking of the trigger finger is sufficient for the diagnosis. And incidence of this disorder, it's very important that it is associated with the actual duration of the disease, not with the glycemic control. And the treatment consists of immobilization with splinting, NSAID, corticosteroid injection, and surgical release. So this is a picture of trigger finger. On palpation, you can easily find the nodules at the base of the finger. Frozen shoulder, one of the common conditions, is characterized by insidious and the progressive loss of the active and passive mobility of the shoulder joint. due to the capsular contraction. And the prevalence is around 11 to 30%. Long duration diabetes, poor control can lead to shoulder calcification. And the treatment includes physical therapy, local corticosteroid injection, and the complete recovery. It may take a longer time, even up to 4 to 8 months. So this is the photograph. In the first photograph, you can see the shoulder capsules are non-inflamed, healthy, and second one related to the frozen shoulder, where the shoulder capsule is inflamed and lead to painful mobility. Now osteoporosis. Diabetes is an added risk factor for osteoporosis, and it can lead to increased risk of fracture in women and elderly. The hip fracture risk is increased by about 6 to 9 times. And in the type 1 diabetes, that is the reduced insulin and insulin-like growth factor is the main cause of the reduced bone mineral density, and it can occur in diabetic patients as a direct consequence of the disease, but it can also be a treatment manifestation. We all know iodine is very prone to develop osteoporosis in bone. Normoglycemia, exercise, and supplements are very helpful in managing this condition. So this is the classic picture of osteoporosis. We can see here that the fourth lumbar vertebra is demonstrated. Now, diffuse idiopathic skeletal hyperostosis is the ligamentous ossification of the anterolateral aspect of the spine column, and it is an asymptomatic condition, but numerous clinical symptoms can develop, including pain, stiffness, limited range of tunnel motion, and increased susceptibility of the fracture. Insulin has been proposed as a factor that can promote growth in this vascular disease. And the diagnosis of vascular disease is based on the radiological feature. Treatment is mainly symptomatic. You can see the yellow arrow is classically showing the ossification of the anterior ligaments. Now, Charcot joint. Charcot osteoarthropathy is associated with the long-standing duration of the diabetes and associated with peripheral neuropathy. A reduction in the normal afferent protective neural impulses and therefore loss of protection from the trauma to the joint leads to the progressive painless joint destruction. It is characterized in the early stage by the acute inflammation without pain that leads to the bone and joint fracture, dislocation, instability, new bone formation, and gross deformities. And the progressive bone resorption, fracture, dislocation increases the deformity and classical rocker bottom appearance observed in the foot. And the treatment is based upon the disease stage. Initially, we can immobilize and with the total contact plaster, and rest can prevent the further destruction of the joint. Appropriate orthosis and the crutches, and in the last stage, the fusion of the joint, that is orthosis, is option. So this is the classical picture of the Charcot joints. We can see the deformed foot with the clawing of the toe, and the curvature is increased convexally downward, that is rocker bottom. The carpal tunnel syndrome is a painful disorder caused by the compression of the median nerve in the carpal tunnel. The severity of the disease is not related to the duration, but rather to its association with different microvascular complications. The clinical features include nocturnal paresthesia, spontaneous pain along the distribution of the median nerve in the hand. Second sign, renal sign, and talent tests are positive. The diagnosis becomes definite in the nerve conduction test, and the treatment is consists of conservative measure or surgical release. Of the conservative measure, only splinting and the corticosteroid are supported with the high quality evidence. So this is the picture of carpal tunnel syndrome, where the nerve is compressed in the carpal tunnel, and paresthesia, numbness, and pain is seen in the fingers, which are which are median nerve, that is thumb, index finger, middle finger, and half of the ring finger. Diabetic hemorrhage is characterized by burning, severe itching, and lancinating pain in the hip and the thigh, followed by weakness and marked weight loss. You can see the weight loss up to 30 to 40% in the case of diabetic hemorrhage. The most likely mechanism of this condition is inflammatory, immune-mediated lumbosacral radiculoflexopathy, and the treatment includes immunosuppressive therapy in the form of IVIG and high-dose methylprednisolone, in addition to good glycemic control with marked recovery in majority of the patient is seen. So this is the classical picture of the diabetic hemorrhage. We can see the wasting of the muscle, which may be very painful. Reflex sympathetic dystrophy. It is also known as algodystrophy, select dystrophy, and chronic regional pain syndrome type 1. Typically, it presents with the allodynia, burning pain, and hyperalgesia with marked autonomic features. Main modality of treatment are analgesic, physiotherapy, bisphosphonates, oral corticosteroid, and sympathetic ganglion blockage. The outcome is usually good, and some patients may develop the chronic pain and contracture in the hand. So this is the classical picture of reflex dystrophy, where the hand is seen to be painful and swollen. Pseudomotor sign will be present. Now the last is diabetic muscle infarction. Diabetic muscle infarction has an acute onset characterized by muscle pain and swelling. High muscles are the most frequently involved, followed by the calf muscle, and it is most commonly seen in insulin-dependent diabetic mellitus. Diffuse diabetic microangiopathy, hypercoagulability, vascular endothelial damage, and advanced atherosclerosis are the responsible mechanism. MRI is the diagnostic test, and it gives a typical picture on T2 weighted images with the marked muscle edema. And the recommended management is symptomatic with pain relief, and short-term immobilization is needed. So this is the condition of diabetic muscle infarction. You can see in the MRI, the edema is there in the. So the take-home message is diabetic mellitus is a systemic disease, not only causes metabolic problem, but also can lead to a wide variety of musculoskeletal problems. Assessment and early management of musculoskeletal problem in diabetic patient can prevent the pain and the morbidity. Euglycemia and exercise are important for primary prevention as well as the disease management. Different orthosis, physiotherapy, splinting, medication, and surgery are needed for different rheumatic manifestations. Thank you.
Extremely sorry that no questions would be allowed just now. Now, I would request Dr. Ccdsicon to remain on the dais. And so, very good afternoon, first all of you. And I would like to distance to go.
Good afternoon, everybody. I must say thank to organizer for giving me this opportunity. So after masterly talk by Dr. Sudhir, my topic is also very common, the thrombolysis. There is always question whether we should do the thrombolysis or not, or what is the appropriate time, or what is the dose. So there is always confusion regarding thrombosis. So we should start how and why thrombolysis is required, and what is role of thrombolysis. So when heart attack takes place, initially it started with plaque rupture. Here you can see the plaque, the yellow is the plaque, then there is rupture. The plaque material goes into the artery. So there is activation of platelet, and that will cause activation of coagulation system also. So after plaque rupture, there is activation of platelet, then there is activation of coagulation system, and
get deposited over there. So ultimately, the prothrombin converted from so this fibrin form a form base for the clot formation. It is the escape hole for the clot, and it makes the clot solidify. It can block the artery easily, and it cannot be break the usual drugs. So when we go to history, James Herrick in 1912, he mentioned that after doing the autopsy of one of the myocardial patients, the whole core damaged myocardium lies in the direction of securing the supply of the blood. So almost 50 years gone to prove this, whether death was due to the blockage in the artery or blockage takes place because of the death. So there was confusion initially in the 19th century. So then the things were settled. The first use of thrombolytic therapy with patients with acute myocardial infarction was reported by Fletcher and colleagues in 1958. So 1958, the first thrombolysis was done, and more than 2 lakh patients has been randomized in clinical trial of thrombolytic therapy. Other area of medicine has the therapy so extensively. So it was the most extensively studied area. So how it works? The plasminogen is get converted to plasmin by these medicine like streptokinase, the LT plays, the TET plays, and the plasmin convert the fibrin into fibrinogen. So this the most important thing is fibrin. It should be break to open the artery. So that's why the thrombolysis is required, and after thrombolysis, all the other medicine like to break the platelet, break the viscous cycle of proteolysis is also required. So this study was published in Circulation 1998. According to this study, they mentioned that thrombolysis is life-saving, and in every aspect from 0 hour to up to 12 hours, there was benefit. So in 1998, before 1998, it was clear that up to 12 hours we will do thrombolysis, there is motility benefit, and after 12 hours the motility benefit was less. So according to this, the ideal thrombolytic agent should be rapid perfusion. It should be given 30 to 100 efficacy for reperfusion can be given as rapid venous injection, low rate of intracranial hemorrhage, low rate of systemic bleeding, specific for recent thrombi, low rate for early reperfusion, sustained patency on long term, no effect on blood pressure. So these are the ideal characteristics should be in thrombolytic therapy. So why thrombolysis is important? With every minute there is myocardium dying. So within a few minutes there is damage of myocardium. As the time goes on, the extent of damage is more. So early opening of the artery is very important. Otherwise, if it is delayed, the death will be more. So definitely the rapid perfusion is very important, and every minute counts. So this is very important to open the artery as early as possible to save the important myocardium, because if myocardium is hard to live later on. So it is very important to reverse the pressure, to arrest the myocardial infarction at that time, and this is very important. So we can arrest the process by 2 ways. We can do it mechanically. We can pass a wall through the artery. We can put a balloon, and balloon can be directed, and then stent can be placed. So by doing this, we can establish the flow, and that is TIMI-3 flow, means normal flow. TIMI-0 sluggish flow, and we can establish the TIMI-3 flow easily with angioplasty. The second option is we can do the thrombolysis, and with thrombolysis, fibrin get destroyed. It will convert into soluble fibrin product, and patency can be maintained. So by both the method, we can solve this problem. So by doing the thrombolysis, main thing is whether the whole clot will dissolve or not. So like in this ECG, where here we can see the upper one is how to, this is also important, how to see the response. So in upper ECG, you can see that there is ST elevation from V1 to V4. So this is massive myocardial infarction because in maximum leads there is changing and there is reciprocal dictation second, third wave also. So this is massive myocardial infarction, and after 60 minutes of thrombolysis, there is response. So settlement of the ST segment elevation is there. So there is positive response. If positive response is not there, that means the clot is not dissolved and patient will require rescue PCI. So in this condition, if response is not there, if ST segment is not settled, rescue PCI is required. So in all those hospitals, if rescue PCI facility is not there, the patient will not be saved and recurrent MI can take place and heart failure and cardiac shock can take place. So in this patient, there is a response, but if there is no response, the PCI will be required. So every minute counts. So what happens if the ambulance is in the road? So what will, where is the minute? It can take hour from here, especially the Jammu and other places. So our main meter will get defeated. So can we do pre-hospital thrombolysis? It is very important. If we do thrombolysis inside the hospital, the early the artery will open, the more myocardium will be saved. So is it there is evidence in favor of this? So according to this trial, this is STREAM trial. This trial was released in 2013, and in 3 hours they did the thrombolysis inside the hospital, inside the ambulance, and the rest of the patient did the PCI. So the result was that it was almost result was similar in PCI group as well as thrombolysis group. The reduction was almost same. So it was feasible, it was useful also, and early you will start the thrombolysis, the better will be the benefit. So this is the only thing about that in some of the patient, almost 36% of patients were requiring urgent angiography in thrombolysis group. So, and there was more intracranial hemorrhage by almost 1.6% in thrombolysis group. So more hemorrhage was there, and recurrent PCI or rescue PCI was required in this patient. Although mortality was same, only a stroke event was there in this trial. So another trial was Captain trial. This is also very important trial, last trial. And this is the follow-up of the 5-year follow-up, and the mortality was same in both the group. In thrombolysis group, which was done in pre-hospital. In these trials, within 6 hours, pre-hospital thrombolysis was done. So it is feasible to do the thrombolysis. It was safe, and it was as good as PCI if done early possible. So we have two options. We can do the primary PCI facility all available within 3 hours, or we can do thrombolysis within 3 hours. Reduction. If we are getting the patient between 3 hours to 12 hours, we can do PCI, we can do the thrombolysis, we can send those patients for primary PCI, and primary PCI can be done within 24 hours. That is called pharmacoinvasive PCI. If we are getting patient after 12 hours, there is more so thrombolysis is not effective. If some patient develop recurrent MI, if some patient develop heart failure, if patient is cardiac shock, in all those conditions, primary PCI is better because it establishes the flow mechanically. It establishes the flow. So, if synergy is there with PCI and thrombolysis, there is benefit. So in 1986, the trial was done only with thrombolysis, and their mortality was 13%. Then arrival was streptokinase, then arrival with aspirin and streptokinase, TPI was added. So there was decrease in mortality, and after this trial, the origin MI, the mortality in MI was almost 2.5%. So with improved stent, with improved patency, and with improved synergy between the thrombolysis and PCI, the mortality was much less in this trial. So these are the terms which is used, often used, the first medical contact. First medical contact means the first person who can diagnose the condition, the MI at the place. ST elevation diagnosis should be done within 10 minutes of first contact. The primary PCI should be done within 12 hours of infarct-related artery, and rescue PCI when thrombolysis is failed, if the PCI can be done. So these are, and the pharmacokinetic study means you give the thrombolysis and you do the PCI up within 24 hours. That is pharmacokinetic. These are the common term which is used. So what is the ideal condition? Ideally, there should not be any patient delay. If there is chest pain, patient should cut it immediately to the competent doctor. So here in patient part, there is always gas problem. Am I friend? Am I always and all explain with the gas? Even the doctor, they are much delay, and this is a very common problem. The other thing is the system delay. So ideally, if the first medical contact is there, within 10 minutes, the thing should be diagnosed. And if diagnosis is done, in that condition, if possible, if primary PCI is possible within 120 minutes, meaning if primary PCI is possible in that time within 2 hours, it should be done, and it should be done as early as possible. If not possible, in that condition, the thrombolysis should be done, and ideally thrombolysis should be done within 10 minutes. So in Bihar, there is always a problem. Even related is wanted to explain that whether thrombolysis or not, the patient time because of this could be a gas problem. There is inherent delay doing ECG, and there is inherent delay in the diagnosing the condition. Ideally, the ambulance, it can be diagnosed. If possible, the staff can diagnose the condition, or he can send the ECG with WhatsApp or other group to the core hospital, and the thing should be diagnosed within 10 minutes. That is the ideal condition. So ideally, this should be the condition. So first medical contact to ECG and diagnosis should be within 10 minutes. If possible, PCI should be within 2 hours. If possible, thrombolysis should be done within 10 minutes. So these are the thrombolytic agents. The streptokinase, it is given 1.5 million units. The L-triplase, which is given. So these are the fibrin specific product, tenecteplase and reteplase and L-triplase, and the non-fibrin, the streptokinase is there. So there are other indications of thrombolysis also, like in a stroke, it can be used. If a stroke is mild to moderate, it can be used up to 4.5 hours. It is drug of choice in case of pulmonary embolism, if RV function is jeopardized, or if there is a shock because of pulmonary embolism. If thrombus is there inside and it's threatening the limb, in that condition, thrombolysis can be done. In a stuck valve, if mechanical valve is there, it can be done. So in summary, it is relevant. Thrombolysis is relevant in every aspect, and it should be done, and there should not be delay in everything. And there is inherent fear that the patient can have intracranial hemorrhage. But only 3 conditions are: if advanced age is there, his weight is less, if female sex is there. In all these conditions, the chances of intracranial hemorrhage is there. So we should recognize all advanced age. So we should recognize all those groups, and we should not thrombolize in those group patients. And there should be ease of administration, particularly in pre-hospital thrombolysis. The venous drugs should be used, like tenecteplase, and there should not be any taboo in using the thrombolysis, because it is life-saving. If intracranial hemorrhage disease, it is around 1% or 1.5%. But the life saving is around 15 to 18%. So it should be given, and we should look for the contraindication also. If there is intracranial hemorrhage, AV malformation, if there is large surgery. So if at presentation very high blood pressure is there, so contraindication, we should remember that, and we should look for the response for the therapy. If thrombolysis has been done, after 60 minutes, ECG should be done, and whether the settlement of STT segment more than 50% or not. If it is failed, we should send this patient immediately for the rescue PCI and early transfer. If thrombolysis is done, it should be transferred to PCI capable hospital as early as possible, because within 24 hours, the angiography and the pharmacokinetic PCI should be done to save important life and save recurrent MI, to save cardiac shock and all other complications. And there should be synergy between the physician and the cardiologist, and there should be synergy between the pharmacokinetic therapy, the thrombolysis, and primary PCI. Thank you.
Thank you, Dr. Veeran. Please stay on the dais. And now I would request Dr. Shambhu to Our next speaker is Dr. Shamshad. And topic is very interesting from cardiology and physician point of view. It's approach to a patient of syncope. Dr. Shamshad, welcome. Nice.
डिस्प्ले कर दो राइट डिस्प्ले कर दो
Yeah, good morning, everyone, and I'm very thankful for being invited to this platform. So today we will be discussing about how to approach a syncope. It is a very vast topic. It will be quite difficult to cover up in 15 minutes. Because we have to classify whether it is cardiac or non-cardiac, neurological syncope or other idiopathic causes. Let's start. Usually the best thing which is available to us for approaching a syncope are the guidelines, whether ASCC or ESC guidelines. ESC guidelines, they are the best one because these are the more apt when it comes to our Indian population. So let's first define syncope. It is a transient loss of consciousness which is due to transient global cerebral hypoperfusion. It has a rapid onset, it should be a short duration, and it should have a spontaneous complete recovery. Any syncope which is not having a complete recovery, it is not a syncope, it is a stroke. Other definition which should be kept in mind are what is a transient loss of consciousness? It is a state of real or apparent loss of consciousness with loss of awareness, and it should be characterized by amnesia for that period of unconsciousness, abnormal motor control, loss of responsiveness, and it should be of short duration. It is a syncope when the features of reflex, orthostatic hypotension, or cardiac syncope are there. And also specific features of other forms of syncope, such as seizures, they should be absent to classify it as syncope. This is a basic classification of transient loss of consciousness. One is traumatic, usually seen after head trauma, and others are non-traumatic, which can be classified as syncope due to reflex, orthostatic, or cardiac. Epileptic seizure, psychogenic syncope, psychogenic transient loss of consciousness, and other rare causes, which can be vascular causes or causes due to vertebrodactyly, TIA, hemorrhage, and cyanotic children. The reflex syncope, it can be reclassified into vasovagal syncope. It is usually orthostatic. Situational syncopes associated with micturition. We often confront patients who say that I have got a syncope while in the bathroom. So we usually ask them कि क्या आपको ऐसा हुआ था कि पेशाब जोर से लगी थी, उसके बाद पेशाब करने गया और बेहोश हो गए. So this is a typical history which is seen. At times, syncopal patients, because we know that in our patients of Bihar, they have their own reasoning. But they diagnose the reason why it has occurred. At times, patients come with syncope and they say that gas ban gaya or syncope ho gaya. It is not gas formation. This is basically a gastrointestinal stimulation associated syncope. It can occur. Usually, it is precipitated by abdominal discomfort and abdominal pain too. Those associated with cough or sneeze. We have confronted a lot of patients during COVID times. COVID times, the prevalence of syncope increased. That was basically due to recurrent cough. And it was associated with syncope because recurrent cough excites vagal stimulation. Others are post-exercise, laughing continuously, and other syncope are reflex syncope are due to thyroid sinus syndrome and other non-classical forms. Due to orthostatic hypotension, they can be drug-related. Most commonly, drug which is used is diuretic-associated orthostatic hypotension is commonly seen, and others are which our population most commonly use is the drugs for BPH, benign prostatic hyperplasia. Usually, it is said that those drugs should be taken at night, but usually most of the patients take it in the morning. So that's why syncope is precipitated by these drugs too. And other common reasons which in summer, volume depletion, hypovolemia, primary autonomic failure mostly in the patients of multiple system atrophy and Parkinson's disease, and other neurogenic causes can be seen. What comes to a cardiologist perspective, basically my perspective is cardiac reasons of syncope. Usually they are mostly associated with arrhythmia. Bradyarrhythmia are more common as compared to tachyarrhythmia. Also, the structural heart diseases, most commonly severe aortic stenosis, they are associated with syncope. At times, patients with hypertrophic cardiomyopathy, due to dynamic LVOT obstruction, syncope is seen in these patients, and those patients who have atrial myxoma, young patients, if they present with syncope and we suspect a structural abnormality, they can present with atrial myxoma, which remains undiagnosed if a good echo is not done. And cardiopulmonary blood vessel pulmonary embolism, and those cases of severe pulmonary embolism, they usually present with syncope, first presentation. So these are the classification, the pathophysiology of different kinds of syncope varies. At times it is not said that a single pathophysiology is responsible for a single kind of syncope. It can be related to other kinds of syncope too. So these all pathophysiology are interconnected. That's why this circle is made. This is a diagrammatic description, a depiction for understanding the pathophysiology. So as we have a less amount of time, we have to move forward as fast as possible. When it comes to epidemiology, the most common cause of syncope as per the Framingham data, it is idiopathic. Unexplained syncope, they are most common. But when it comes to assessment from data from the emergency department, reflex syncope is the most common cause of syncope. Whenever a patient of transient loss of consciousness presents, and if we diagnose it as a syncope, then initial examination, ECG, whatever is required, we do. If there is a certain diagnosis which is made in the emergency department, then obviously treatment is to be done. But most of the cases, they are not diagnosed exactly in the emergency. So risk stratification has to be done, whether we need to admit these patients and further proceed with further investigation or not. If the patient is low risk, very rare events of syncope, then obviously these do not need any further evaluation. They can be sent off home, and they say, we have to say that if this occurs, then you have to come back again. But low to medium risk patient and also high risk patient, these patients have to be admitted at least. High risk have to be admitted in IPD, and low to intermediate risk patient have to be taken for a daycare kind of management. So this is the flow chart which has to be followed, which I have discussed just now. History is very important. Vasovagal syncope has a typical history. Precipitating factors are there: fear, standing, long, prolonged standing, or summers. As summers are coming, so sweating, prolonged sweating is a very important contributing factor. Situational syncope can occur during defecation, urination, and orthostatic hypotension. Diagnostic criteria: whenever we get ECG with a complete heart block or Morbitz type 2 heart block, alternating left and right bundle branch block, and also non-sustained or sustained events of VT or rapid onset of paroxysmal SVT, then obviously these are cardiac causes of syncope. And if the patient is on pacemaker or AICD, if any malfunction is there, they can really be responsible for syncope. And not only cardiac arrhythmias cause it, even cardiac ischemia also lead to syncope. So acute myocardial infarction, they often present with syncope. Usually these are most commonly seen with inferior wall myocardial infarction. Even in absence of any arrhythmia or even in absence of any heart block, these patients present with syncope. Usually when right ventricle is involved in inferior wall myocardial infarction, and obviously the blood flow from right side of the heart to the lungs is impaired. But that obviously leads to hypotension, and that leads to syncope. These are the echo when it is required in case of atrial myxoma, ball valve thrombus, severe aortic stenosis, and pulmonary embolism, and acute aortic dissection. When it involves the carotid, it has the dissection flap. When it moves towards the carotid artery, extension of the carotid, then it leads to syncope too. When we require blood tests, so basic blood test has to be done in every patient, because we have to rule out whether the patient is hypovolemic or not, anemia is there or not, if the patient is cyanotic, if the oxygen saturation is in the required amount or not. We have to rule out pulmonary embolism. For that, D-dimer test is required. Any myocardial infarction has to be ruled out for cardiac ischemia related syncope. the clinical features and ECG, they have to be matched. Whenever we deal with a patient of syncope, we should not be a robot. Basically, we have to match the clinical features and associated investigation, the results which we are getting. That's why we can further approach and further follow up, manage these patients. So the history, different maneuvers, different exposures, they have to be find out in these patients whenever we approach these patients. So this is the initial evaluation. Whenever there is uncertain diagnosis, if we suspect it is a cardiac, so obviously echocardiogram, ECG is required, APS study if required. We can go for a stress test and coronary angiogram if it is required. We have to do that. If we are thinking that the cardiac cause is unlikely, then ECG monitoring and implantable loop recorders or external loop recorders can be used. If we are very much sure that this is not a cardiac cause of syncope, then obviously no cardiac investigation is required, and we have to reassess these patients. That's what we are dealing with. The basic, whenever we deal with autonomic failure, we have to perform active standing test. We have to monitor blood pressure fall and heart rate increase or any heart rate fall in that patient. Valsalva manual deep breathing, carotid sinus massage, tilt table test, which is very rarely used nowadays, and ambulatory BP monitoring has to be done. The active standing test, we say that after 3 minutes, if any significant fall in blood pressure, that is 20 mm systolic blood pressure or 10 mm diastolic blood pressure, or a heart rate decrease, it is seen, then these can be contributing to the cardioinhibitive reflex syncope, basically. The response is of two different types, whether it is cardioinhibitory or vasodilatory. In vasodilatory, usually blood pressure is falling, but in cardioinhibitory, the heart rate also falls. These are the guidelines of ESC, that how we have to do standing test, and what are the predictors which say that if these changes are seen, then these patients have to be further evaluated and managed. Carotid sinus massage, any asystole for more than 3 seconds or any blood pressure fall of more than 50 mm, then it is said to be a positive test. If it is associated with symptom, then it is carotid sinus syndrome. If it is not associated with symptoms, it is carotid sinus hypersensitivity. These are the graphs which you usually get when we perform carotid sinus massage. So the indication of carotid sinus massage, any patient below 40 years, usually it should not be done, because carotid sinus hypersensitivity, even it is not seen in younger patient. When it comes to ECG monitoring, different types of ECG criteria has been prefixed for these patients. Type 1 is asystole. Asystole usually leads, it combines about complete heart block, sinus arrest, AV block, or type 2 AV block. Bradycardia, if the heart rate is more than 30% or heart rate is less than 40 beats per minute, slight rhythm disorder, but uncertain effects of that rhythm disorders are seen. And finally, tachycardia, usually rapid onset supraventricular tachycardia and ventricular tachycardia. ECG indications of ECG, we now at time we see that any patient of syncope, everyone is ordering a 24-hour Holter test. It should not be a universal test for everyone. There are guidelines that when we have to do a long-term ECG monitoring and what kind of long-term ECG monitoring has to be done. So whenever the symptoms are uncertain and we are not able to diagnose, if it is a high-risk patient, high-risk criteria have been depicted. If the patient fulfills those criteria, then obviously the patient has to be admitted. In hospital, ECG monitoring has to be done in these patients. If in hospital ECG monitoring is negative, then these patients have to be implanted an ILR. Implantable loop recorder has to be done for these patients, so that a long-term ECG continuous monitoring should be done in these patients. Whenever an event occurs, we can easily catch these. In low risk but arrhythmia prone patient, we have to go for ILR. It is a class 1 indication, or ELR. That is a external loop recorder. It is usually performed for 7 days. It is a 7 days Holter. Or if it is not available, then we can go with a 24-hour Holter test. So the importance of Holter monitoring, it is very low. It should not be used that much frequently as compared to external loop recorder or internal loop recorder, implantable loop recorder. And if for low risk patient also, we need a
ILR, those patients who experience symptom at prolonged intervals. Suppose if a patient is experiencing syncope once in a month, then obviously our 24-hour Holter test is not going to catch that. Even 7 days Holter monitoring, ELR is not going to catch that. So we need ILR in those patients. And if the episodes are very rare, suppose the episodes are usually at 3 months or 6 months, then no monitoring is going to benefit. We are not going to achieve anything by doing any prolonged monitoring. So these are the diagnostic criteria. EP study, it has to be done when where we suspect that it is due to any arrhythmia and we are not able to diagnose that. Then we have to induce that arrhythmia on electrophysiology lab. Echocardiography, if we are suspecting any structural disease which might lead to syncope, usually severe aortic stenosis, hypertrophic cardiomyopathy, left atrial myxoma, or any kind of ball valve thrombus, if it is obstructing in forward flow in the heart, then obviously it has to be ruled out. Exercise testing, it is very rarely required, but there are certain subsets of patients, especially nowadays, younger patients, they experience syncope after doing gym or after doing exercise. So then in these patients, we have to perform exercise testing. We have to induce whether if syncope is occurring after exercise or during exercise or not, whether we are getting any ECG changes during exercise or after exercise. And finally, need of coronary angiogram. So the indication of coronary angiogram, it is not different for those patients of syncope. The guidelines remain same, what it is done for coronary artery disease patient. So that same guideline has to be followed for coronary angiogram in these patients too. Thank you.
Thank you, Dr. Samshad Alam. Kindly be seated on the dais. And for the last talk, I would request Dr. Sumit Kumar Verma. We will be presenting few interesting cases.
Good afternoon, everyone. Without wasting time, I am directly proceeding to my case. Yes. I see a case who comes to my OPD thoracic and mitral valve replacement 18 months back, presented with persistent dry cough for 5 days, shortness of breath which increased in last 5 days, and at present patient is dyspneic even at rest. She was survived 5 days back, but fever subsided in the next 48 hours. The history itself says the diagnosis, but proceeding further, she is on warfarin 2 milligram and diuretics. We are also taking antibiotic, anti-allergic and antitussive for last 5 days. I am only explaining the relevant things. On general examination, pulse was PCS tachycardia. It was 112 per minute and BP was 90 millimeter of Hg systolic. What should be the next investigation for decision making? I opt for echo, and let's see what happened there. Okay. So here is the echo picture. The cursor is along the LA. Here you can see that there is pressure gradient between LA and LV, that the mean pressure is 36.70. The normal limit is 5, that is 36.70. So from here you can directly say there is obstruction between the LA and LV. So it is a case of, and the onset is acute. So it is a case of a stuck mitral valve due to thrombus, acute thrombus. It is further physics of TB I don't want to go into it. So if the diagnosis of stuck mitral valve was made, and after that the routine examinations come, and then the INR was 1.7. So we have option there for thrombolysis because of the cost burden of the surgery
I gave her the thrombolysis and patient was put on the continuous infusion of the streptokinase for 24 hours. Patient dyspnea and cup subsided and repeat to be done after 24 hours. And here in this echo, we can see the mean pressure gradient decreased to 3, that is a normal. So after that, target INR was achieved by low molecular weight heparin and warfarin. The patient was conceived about the importance of INR after replacement surgery and discharge. This is the first case. The second one is a 62-year-old case of type 2 diabetes, arterial disease, CKD, presented with shortness of breath on exertion with minimum effort. Dry cough, more on lying down posture, and all complained with last 1.5 months. He didn't have any history of chest pain during this period. So I took the drug history and patient was on metformin, rheumatoid, empagliflozin, sitagliptin, torsemide, and intermittent inhaler. Blood reports are the relevant things is the anti-PVMP, which is 2700, and CRP, it was 11. The diabetic status was uncontrolled. So, and further growth of diabetes was increased twice in last 1 month as per record, but there was no satisfactory improvement in patient symptom. After that, the report of 3 months back to research concentric LVH with normal EF. After seeing the report, I just asked the patient why he went to the cardiologist for echocardiography. Then told me that 3 months back I have a big chest pain that was not fully explained by him, and it was subsided in 1 to 2 days. So patient went to the cardiologist and they was done, it was okay. And then patient said that I was okay. And after that, after 3 to 4 weeks, I started developing shortness of breath. So the physical examination then, it was relevant before 100 times less 20 pulse of patient. Again, the patient has tachycardia, very depleted edema. In ECG, there are sinus tachycardia and specific STT changes. So I did again the 2D echo, and here, as the slide, the patient was not prepared for the academic purpose, I just put what I did. Echo was not done according to the academic protocol. But here, what we can see there is a pericardial effusion of 12 mm. There is no early diastolic collapse, so no evidence of cardiac tamponade. And yes, there is brightening of pericardium. So there is increased thickness of pericardium. It is around 6 mm. Though it is not accurate to say that somehow at some level it suggests there is increase in thickness of pericardium. So, and there was also across the mitral flow, the blood flow across mitral valve was seen. There was almost 20% variation of the blood flow across a mitral valve with respiration. So it shows there may be the diagnosis was the pericardial effusion with effusive constricted physiology. It was not effusive constricted pericarditis, but effusive constricted physiology. So I have options 3 drugs we can use: Rivera, NSAID, corticosteroids, and colchicine. But because of the renal status and diabetic status, I prefer colchicine as first choice, and 0.5 milligram. It was given according to the renal modified dose, but the patient did not tolerate this, even this dose. So I reduced it to 0.5 milligram alternate day. After 3 weeks, I repeated 2D echo, and here there is no pericardial effusion, and also there is decrease in pericardial thickness. And perhaps the next slide. Yes, it has reduced to fluid mm. So there is a settlement of and patient. This is the echo picture, and there was drastic improvement in patients' NIH status. So change on coagulation, and there is patient may develop constrictive pericarditis. So put the patient to continue on the coagulation for the next 3 months. After that, I will plan to withdraw this after 3 months. So in every cardiac dyspnea, diuretics are not effective. Thank you.
Thank you, Dr. Smith. Please stay with us. And now we would have the felicitation ceremony.
Thank you so much, sir. And I would expect each one of us to have this teachers, so this is not now, without any further reading, there is a meeting of the ceremony of the session. And after this, Dr. Ajit, Dr. Rito, and thank you so much for explaining your experience, salary time of the political government. However, this is how we are looking at the session. I know, Dr. Dinesh Kumar sir will be on the chair of the session. When I come forward, our people of the Sunshine sir, Dr. Dinesh Kumar after that, and I will now request Dr. Shamu Kumar sir will be on the chair for the particular session. I would request our moderator of the meeting, Aditya, as well as Dr. Bhai, Dr. Dinesh, and Dr. Shamu. All the shareholders or the presentation. And I will request Dr. Dinesh, I am not over and I'm not the moderator of the meeting. And I will request all of you. Let the revenue come from the what you want.
But now, yeah,
और सभी लोगों के अनुरोध में क्या पूरा आगे रखें ताकि हमारी क्लैरिटी ये करें हमारे गाँव को बहुत ही क्लैरिटी और अनुभव से शांति और आप सभी को मेरे बहुत बहुत धन्यवाद each one to all the speakers who are already shared. So, because you can see they are only under the session. We are all second from the next session. And already Thank you.
Good afternoon to everyone. I welcome you all in this last plenary session of today. It is completely dedicated to the nephrology. There are 3 different talks which are very brilliantly chosen from the different parts of the nephrology, which we come across in the daily practice. And there is one case presentation. So just cut down the time. I will call upon the chairpersons, Dr. Om Kumar, Dr. P.K. Singh, Dr. Padmakar Singh, and Dr. Rupak Kumar Singh on the dais. The first topic is dedicated to the management of kidney disease in the diabetic patients. This is the most common problem we come across the practice. There are 2 main important pillars in the management of the diabetic, the control of the hypertension and hyperglycemia. But there could be some other factors which may modify the disease, like dietary modification, control of hyperlipidemia. There could be drugs which may modify the intraglomerular pressure and the intraglomerular hyperfiltration. So these will be discussed by our esteemed speakers. I hand over the mic to our chairpersons to introduce the speakers.
One of the most renowned nephrologists as we have. Medical College and also heading the department of nephrology at Ruben Memorial Hospital. Speaker in state conferences, zonal conferences, and national conferences. He is a very learned nephrologist. So without wasting time, I request Dr. Pankaj to deliver his lecture on management of CKD in diabetics. His lecture very carefully because it is very important and tricky one. Dr. Pankaj.
Honorable Sir, respected chairperson, seniors and my dear colleagues. My presentation is like match. I will try to justify it. So as we all know, diabetes is quite common in India and beyond the diabetic capital of the world. And so far as CKD is concerned, numerous studies have been done, and it has been found that the prevalence of CKD is from 6 to 17%, averaging 2.4%. And you all must be familiar with this heat map of CKD. And active intervention is needed, and timely referral is needed in these stages. Not going to discuss the staging, coming to the topic proper. So for diagnosing CKD in diabetes, what is needed is screening. And all these odd guidelines, ADA, KDIGO, ESC, and combined ADA, KDIGO consensus guideline, they recommend the necessity of screening. How to screen? 2 ways, 2 methods. One is
the estimation of urinary albumin creatinine ratio, and the second one is to measure the eGFR. You go by serum creatinine, you go by eGFR. And the frequency should be annually, and in some cases, this frequency may be decreased if the patient is a high-risk patient. So the red ones, as I told, these stages need referral to a nephrologist timely so that active interventions may be done. Coming to the topic of management, glycemic control. I am not going to discuss DCCT and UKPDS. You all are quite versed with those things. I will discuss only those changes that has occurred over the last 5 years. So this is, we all know. Now this, previously we said that tight control of diabetes is needed in a patient suffering from diabetic kidney disease, and the HbA1c should be around 6.5 to 7. But it has been now come into literature that it has to be individualized depending upon a stage of CKD, presence of microvascular complications, comorbidities, life expectancy and associated hypoglycemias, etc. If the patient belongs to higher grades of CKD, in that case, the HbA1c should be higher, like 8. And in earlier stages, you can keep HbA1c at the lower level of cutoff, that is 6.5. This slide is very important for all of us to know that when to use metformin and when not to use metformin. So if you come across a patient of diabetes with CKD and the GFR of the patient is less than 30, straightforward, don't initiate metformin. And if the patient has been on metformin, it may be discontinued. If it is more than 30, between 30 to 45, then metformin may be started in 50% of the dose. Above 45, full doses may be initiated, and that has to be titrated at interval of 7 days. And depending upon yearly change of the GFR, you may go on changing the dosing of metformin. The burning topic is SGLT2 inhibitor. Today morning, Dr. Chandramohan has discussed the various cardiological trials in quite detail, like EMPA, CANVAS, DECLARE, etc. These were the primary cardiological trials, and the secondary renal outcomes were studied. Likewise, in EMPA trial, there was 46% risk reduction in the renal outcomes. In the CANVAS and DECLARE TB trial, there was 47% risk reduction in the renal endpoints. So there was a need for dedicated renal outcome trials, and the first such trial was Credence trial. In this trial, the patient selection was in the A3 group and the GFR was less than 60. And as is shown over there, there was 30% risk reduction compared to placebo in the renal outcomes and 20% risk reduction in the cardiovascular outcomes. Then came the famous DAPA-CKD trial, after which the treatment of CKD has been revolutionized. It was done in 21 countries, including India, from where 210 patients participated. Total 4,304 patients were there in this study. Two arms, one was DAPA arm, the second was placebo arm, and this study was stopped prematurely because of the clear-cut benefits that were encountered earlier. So the results were that primary outcomes like sustained decline in eGFR, ESRD, and death from renal or cardiovascular causes that declined by 39%, and overall mortality decreased by 31% in all these patients. And this benefit was not only limited to DKD patients, all patients having CKD because of glomerulonephritis, hypertensive CKD, and other causes of CKD, they also benefited from it. Lastly, in this last year, one trial came, EMPA-CKD trial. Earlier, we used this SGLT2 inhibitors only up to the GFR of 25 or 30. But this EMPA-CKD trial has advocated that this drug can be used up to a GFR of 20, and it has been concluded that among a wide range of patients with CKD who were at risk for progression, EMPA therapy leads to lower risk of progression of CKD or death from cardiovascular causes. This is just a comparison of these three trials: Credence, DAPA-CKD, and EMPA-CKD. Then comes the KDIGO guideline. What does KDIGO guideline say? That apart from the important role of diet, exercise, smoking, and weight, it is metformin and SGLT2 that comes in the hierarchy before RAS inhibitors and statins. That I wanted to emphasize upon you. This is the dosing protocol of various SGLT2 inhibitors, DAPA 10 milligram, EMPA 10 to 25 milligram, and CANA 100 milligram. And the GFR, I told you, EMPA up to 20, CANA up to 30, and DAPA up to 25. This is the recommendation. And if a patient is fasting, undergoing surgery, or is having a critical illness, then these patients, this drug should be discontinued. And there may be a slight reversible decrease of GFR upon starting SGLT2 inhibitors, and this is not an indication to discontinue it. And if you start SGLT2 inhibitor and GFR falls below 20, then there is no point in discontinuing it. It has to be continued. And in kidney transplant recipients, this drug should be avoided. Reasons I will discuss later on if time permits. Now, since most of the patients that come to us are in the advanced stage of CKD, so it is the onus is upon the primary care physicians to start SGLT2 inhibitors well in time. So now this slide already I have discussed. This pie chart actually just discusses the choice of drugs, that if the patient wants to avoid hypoglycemia, then what drug to be used. If they want to cut off the cost, then better you use sulfonylureas and thiazolidinediones. If the patient wants weight loss, then GLP-1 receptor agonist should be used. Now, this chart actually shows that GLP-1 receptor agonists, they can be used up to a stage 5 CKD. That has of late come into literature recently. Now, coming to one newer drug in CKD, that is imaging-based approach for management of DKD. In diabetes, there is actually mitochondrial just as depicted over there. And imaging has been shown to correct this mitochondrial dysfunction and decreases GFR, decreases its HbA1c by about 1. The structure of imeglimin and metformin is quite similar. And it has been first used in Japan with multiple benefits as depicted over here. And this imeglimin has been shown to improve mitochondrial density and function and decreases albuminuria and interstitial fibrosis, thereby helping patients of diabetic kidney disease. The dose is 500 milligram BD if GFR is more than this 15, and below 15, some trials still advocate using it, and it can be very safely used up to a GFR of 15. But I don't say that don't use metformin, start using it, because mara hua hathi bhi sawa lakh ka hi hota hai. It is a famous saying. The metformin is still the drug of choice, not imeglimin. It has cardiovascular benefit also, lesser side effects like reduced lactic acidosis. It improves cardiac interstitial fibrosis and lesser side effects. Then comes the management of hypertension. Hypertension, we very well know the various ACE inhibitors and ARBs when to use. Now there is no cutoff of creatinine above which ACE inhibitor or ARB can't be used. You will start it, the patient should not be dehydrated, he or she must not be in a potassium-rich diet or using a potassium-retaining drug. After 2 to 4 weeks, measure serum potassium and serum creatinine. If the patient is normocalemic, with less than 30% increase in creatinine, you should increase the dose of ACE inhibitor or ARB. If the patient has got hyperkalemia only, then you should review the drug list of the patient and diet of the patient. Start using GI cations, exchangers, and sodium bicarbonate and diuretics. If it is more than 30% rise of serum creatinine, then the various reversible causes of AKI should be thought for. Dehydration and use of NSAID, that should be taken care of, and we should try to rule out bilateral renal artery stenosis in these patients. Now, it has been shown that the rise of creatinine up to 30% after starting ACE inhibitor or ARB is going to help the patient, rather than it is not going to deteriorate the condition. But apart, not only this, in all these trials, it has been shown that this renal, IDNT, microhope, etc., it has been shown that there is not complete blockage of the RAS system. There is aldosterone breakthrough. So can we block the mineralocorticoid receptors and yet not cause hyperkalemia? The answer is nearly yes, with the usage of finerenone. This is a bulky non-steroidal molecule with a high selectivity. Three trials were done. One was a Fidelio trial in which the primary outcomes were the renal failure, sustained decrease of GFR, and death from the renal causes. Cardiological outcomes were MACE and MARE. MACE were the secondary outcomes. Just see the bottom line. The hazard ratio is better with the users of Findrenone, with just marginal increase in the incidence of hyperkalemia. Figaro was just reverse. The primary outcomes were cardiovascular, secondary were renal. MACE was primary, MARE was secondary, and in this study also it has been shown that Findrenone is better as compared to the placebo. The third was the Fidelity trial, which incorporated both Fidelio and Figaro trial, and this trial also showed that by using this Findrenone in patients with DKD, the risk of hyperkalemia doesn't increase markedly, and in the long term, it is going to benefit the patient by decreasing the incidence of ESRD and doubling of. So, what would be the dose of Findrenone? Depending upon the GFR, if the GFR is more than 60, the dose should be 20 milligram per day. Below 25, don't use it. Between 25 to 60, the dose should be 10 milligram. And after 2 to 4 weeks, you measure potassium, and depending upon the level of potassium, you titrate the dose of Findrenone. And all these guidelines, AHA, ACE, ADA, KDIGO, ADA 23, they advocate the uses of Findrenone in the management of diabetic kidney disease. AAC is 1A recommendation, and in KDIGO it is 2A recommendation for this. So the takeaway for Findrenone is famous 5. In this abdominal distension, we use 5A: fat, fluid, feces, fetus, etc. Here also there is 5-5. Initiate treatment when serum potassium is less than 5. Withhold treatment if serum potassium is more than 5.5. Initiate treatment when eGFR is more than 25. Findrenone reduce the risk of EAD by 1/5, and Findrenone reduce the risk of heart failure by more than 1/5. Then comes the other strategies. We all know about aspirin and dual platelet therapy, not going to discuss, and the lifestyle measurements like protein restriction, salt restriction, etc. Proteinuria regression is very important because patients who have got increased proteinuria have got higher grades of loss of GFR. So this should be tackled quite well. So lastly came the consensus guideline between ADA and KDIGO. And this guideline advocates this ACE inhibitor or ARB is recommended in diabetic patients with albuminuria titrated to the highest approved dose, that is 1B recommendation. SGLT2, 1A recommendation up to a GFR of 20. MRS, 2A recommendation. In metformin, 1B indication more than 30 GFR, and GLP-1 receptor agonist, that is 1B recommendation. So I will end by just completing the difference between KDIGO 20 and after 2 years only KDIGO 22 came. Not much of difference. One notable difference was regarding the use of SGLT2. In 2020, it was up to 30 GFR. Now it is up to 20 GFR you can use. And MRS were not there in 2020, and that has been included in 2022. So summarizing, Findrenone should be used in the management of diabetic kidney disease if the GFR is more than 25. We should use this in our patients. SGLT2 inhibitor should be used in patients with type 2 diabetes, CKD, with eGFR less than 20. And if we are not able to control diabetes of the patient, then GLP-1 receptors may be added. This is about the referral. That albuminuria more than 300 and eGFR less than 30 should definitely be referred. And thank you for your patient listening.
Dr. Hans, for in the description of the diabetic. Actually, come in one way. Our GFR loss was about and which has come to about 20 per year due to all the vaccine advancement and per year. So we come in one way and No questions are allowed. I will invite Dr. Kumar to verify the topic. Yes, presentation.
Respected Chairperson, sir, at the outset, I would like to thank the API CCDSI Bihar chapter for conducting this nice Ccdsicon. And as our society is clinical one, so I have some good clinical cases for you. So let us see the first case. A 21-year-old female patient, she presented with weakness of all four limbs that occurred on the prior to her admission. There was no history of trauma, insect or animal bite, loose motion, exposure to insecticides, recent vaccination, fever, headache, blurring of vision, difficulty in swallowing or sensorium. On examination, BP was 100%. On systemic examination, she had hypothermia with grade 1 with power in all limbs. Superficial reflexes were also absent. Other systemic examination was within normal limit. So, CCD, there is a clinical CCD. Can anyone tell what is what this CCD tells to us? Can anyone pick from this CCG? This is the ECG which shows that this is a case of hyperkalemia. Actually, QT prolongation is there, and this is ECG of hyperkalemia. And on investigation, is potassium was 1.4 milligram per liter. Other parameters are normal, and vertical urine analysis showed alkaline urine. Once you are dealing with a case of hypokalemia, then you have to decide two things. First, whether redistribution is occurring or not, because there are several molecules which can cause redistribution of potassium, like alkaline, hypertonic. In this case, what happened? That inside this hyperkalemia, and others we have to decide whether there is a renal loss or extrarenal loss. So it can be decided by either history or by this 24-hour urine collection or spot urine collection creatinine ratio. Besides this, we have to see for acid base estimation. Come to our case, in our case, fractional excretion of potassium is more than 20. It is 20. So there is an inappropriate loss of potassium occurring to kidneys. So we have and metabolic diseases. pH is 7.33, bile is 17.5, sodium 150, and chlorine 113. So we can calculate anion gap in this case, and anion gap is 9.5. So it is a case of normal anion gap metabolic acidosis. So from here, if we summarize our case, it is a case of hypokalemic quadriparesis, non-anion gap metabolic acidosis, high fractional excretion of potassium, and alkaline urine, repeated alkaline urine. So from here, what could be the DD? This is the summary with which our patient had presented. Of course, there is the renal cause and renal tubular acidosis. Once we establish that this is a case of renal tubular acidosis, then various types of renal tubular acidosis, mainly type 2, which is distal and which is proximal. How do we differentiate between type 1 and type 2? Because this patient is showing a difficult alkaline urine, so it is a case of distal renal tubular acidosis, because this time the express excretion is not occurring in the this converted, so
renal acidification is not occurring. So it is a case of distal renal tumour acidosis. Now, distal renal tumour acidosis can occur due to many things. That's kind of often situation evidence in which we read distal renal tumour acidosis. So, in such of cases, we have done this ENA extraordinary antigen examination, then we have found that ANM is strongly positive and NTO is strongly positive, NTO is strongly positive, and others are negative. So the basis of this is a case of hypokalemic disease due to distal renal disease, and it will be due to primary Jordan syndrome. Potassium supplementation, sodium bicarbonate in a and the learning from this case is that Jordan syndrome should be suspected in any patient presenting with hypokalemic paralysis in the presence of renal disease, even in the absence of Zika syndrome. Early recognition of the presence of hypokalemic paralysis due to the underlying this Jordan syndrome RTA with institution of prompt therapy not only helps in treating the potentially life-threatening hypokalemia, but also improves the renal outcome. So this is all about the first case. Any comment? Okay, sir. So moving on to the second case. 28-year-old female. General weakness, even with night sweats and responded she was taking it for last 1 month. All the history are negative. So I'm skipping this slide. Only thing we have found that she had also painful Somebody is a 28-year-old female with fever and constitutional symptoms for 3 month duration. On examination, she was febrile and with bilateral abdominal lymphadenopathy and she was taking NDT for last 1 month. So it was a case of pyroxia of unknown origin, and we all know that pyroxia of unknown origin can be due to infection, can be due to connective tissue disorder, this blood fevers, miscellaneous. So we have been further done in this case. So we have done investigation and found that free blood count has shown normocytic normochronic anemia, leukemia, and ESR 100, CRP is 20, Montex is negative, HIV negative, thyroid function is normal, and other examinations are normal, like chest X-ray, ultrasound. And we have also done lymph biopsy, and that was suggestive of reactive hyperplasia of lymph node. From here, this is the summary. So, but how should we proceed in this case now? This is the summary till this stage. So how? Okay, so thank you, sir. So we have done economy, which is strongly positive, and that is of speckled pattern, and serum C3 is low. So we have done ENA, and that was showing that has anti-histone and anti-RNA is positive, anti-SM positive. So various immune system various. So this is a case of actually SLE, and if you go on this criteria, then it will fit into the SLE. We will discuss something of lymphadenopathy SLE, which is 5 to 7% of cases, and besides the disease, it can occur due to other causes like it was associated with infection, tuberculosis, immunological, and features of SLE and by which we can differentiate it from drug-induced lupus, because in our patient is younger, our patient has CP, and even is spectral, so it can't be drug-induced lupus because and ATP found to be drug-induced lupus. So what should be the In minor SCP plus overall sufficient in the practical weapon and with action of the happening. SCP plus I and my patient has been treated with calcium supplementation, lateral prednisone was covered and CR the last scene. So, learning from this case is that the same needs to be suspected when allergy occurs. When the form of speeches and so so as Dr. Smith has told me that I have to finish within 10 minutes now. Stopping here, I have to, but I'm stopping here. Thank you very much.
We have 2 minutes time. Any comments from the audience or chair?
A very good afternoon to you all. And at the outset, I would like to thank the organizer for giving me this opportunity. And Professor Om Kumar sir, as usual, you have been very kind in introducing me all through my career. So the topic which has been given to me is contrast-induced nephropathy, what a physician needs to know. So in next 15 minutes, I'll try to rush as fast as possible. So I begin with the case. It's a 76-year-old male who was diabetic for 20 years and hypertensive for 15 years. He had underwent coronary angiography for some indication. He was referred on day 7 to us with nausea and vomiting for 3 days, decreased urine output. On examination, he was hypertensive, had pembrolizumab, and his creatinine shot up from a baseline of 3.3 to 8.3. So we suspected something which was happening there, acute and chronic kidney disease. The patient received multiple sessions of hemodialysis and he remained dialysis even after 1 month. So in view of non-recovery of renal function, we did a kidney biopsy, which was suggestive of acute tubulointerstitial nephritis. Case 2 is a very common scenario which we nephrologists encounter in day-to-day practice. He was a 62-year-old male, diabetic for 10 years and hypertensive. He was referred to nephrology OPD for clearance for coronary angiography. His creatinine was 1.7. So what is the risk of contrast-induced nephropathy? So definition of contrast-induced nephropathy is it is a rise in serum creatinine which is more than 0.3 milligram per deciliter, or 0.5 milligram or 25% increase from baseline value, which is assessed at 48 hours after a radiological procedure without an alternative etiology. It was first reported in a case of multiple myeloma who underwent intravenous pyrogram. It was first reported in 1954. It remains the third most important cause of hospital-acquired renal failure. It occurs in around 1.5% of patients without diabetes or CKD, and around 50% of the patients with no diabetes and CKD. There is a wide variation in epidemiology because of definition, the settings which is being used to define the route of administration, underlying kidney disease, and the level of sickness. And as we all know, that renal failure has a great impact on mortality. The type of contrast agent which is routinely available these days are, high osmolar, low osmolar, or isoosmolar, and basically they differentiate on the basis of benzene ring which they are possessing. And the advantages of non-ionic contrast is less cardiac toxicity, less depression of ventricular contractility, fewer hypersensitive reaction, less disruption effect on endothelium. The pathophysiology has been, contrast enters the renal vasculature, leads to some sustained intrarenal vasoconstriction, renal ischemia, and acute kidney injury. Risk factors can be divided into patient-related and the procedure-related. Patient-related, you are having non-modifiable risk factors in which age is most important. Existing chronic kidney disease. Modifiable is anemia, intravascular volume depletion, concomitant use of nephrotoxic drugs. The procedure-related is PCI performed in acute setting, emergent intervention. Modifiable are high contrast volume, high osmolar versus ionic contrast. So what one should do? The KDIGO in 2012 recommends that we should assess the risk of contrast-induced AKI and in particular screen for pre-existing impairment of kidney function in all patients who are considered for a procedure that requires IV contrast administration. So there have been some, scoring systems. The famous one was Mehran, which was introduced way back in 2004, which had certain criteria, and the risk was calculated on that. That was presence of hypertension, use of IOBP, NYHA class 3 or 4, age, anemia, diabetes, contrast media volume. And on the basis of that, you could predict the risk. Then there are some online calculators. This was the calculator which is being calculated, which is all there on your mobile, which you can use. The approach software, which is quite commonly used in Canada. There have been many preventive strategies which are being used. I would just discuss the main things. The use of, the contrast. So the contrast related issues. One should be using as minimum contrast as possible and avoid procedures which requires a very high volume of contrast. And use staged procedures if possible. And the recommendation is either we should be using iso-osmolar or low osmolar iodinated contrast media rather than the high osmolar iodinated contrast media in patients at increased risk of contrast-induced AKI. And there is some suggestion that, you should try to use minimal contrast and use newer technologies to locate the lesion so that you can do interventions. So this was a study in which IVUS was used with very minimal risk of, in fact, there was no reported kidney injury in this study. Hydration as a prophylaxis, we all know, which I'll discuss in later slides. So IV volume expansion is the recommendation right now. So there have been various studies which have proposed that the IV hydration remain the most important and significant strategy in prevention of contrast-associated acute kidney injury, especially those who are having eGFR of less than 30, and prophylaxis may be considered at the discretion of clinicians having GFR which is more than 30. But there is no clear evidence to guide the optimal rate and duration of fluid infusion. But some suggest that it should be given at least 1 hour before and 3 to 12 hours after the doses, which is as fixed as 500 ml or 1 to 3 ml per kg per hour. Then comes NS-style 16. The recommendation is 2T, that is using NAC, which was way back in 2012. Now more data has come. And this was the PRESERVE trial, which was published in 2018, which suggested that IV saline infusion as compared with IV saline with bicarbonate or NS-style 16 was non-inferior. So IV saline remains the method of choice for prevention. And sodium bicarbonate, it had poorly defined mechanism. It may decrease the generation of free radicals and may also scavenge potent oxidants like oxynitrates and other molecules. Then combination strategies, the biggest benefit which the literature suggested was with IV saline infusion and sodium bicarbonate with an N-acetylcysteine. Now again, the important topic is discontinuation of drugs. What you should discontinue. There is some recommendation that eGFR less than 30, one should avoid using high-dose diuretics, ACE inhibitors, ARBs at least 24 hours to 48 hours after the procedures. Definitely one should avoid NSAIDs and other nephrotoxic drugs. Hemodialysis removes more than 80% of the contrast material from plasma within 4 to 5 hours, but does not permit contrast nephropathy. Hemofiltration provides hemodynamic stability as compared to hemodialysis and permits 10 to 15 times the usual hydration without adding intravascular volume. This is the commonest problem which we normally face. Whenever our radiologist colleague, we insist on doing a contrast procedure, they say that we should first you write that you are going to do dialysis after giving contrast. So the current recommendation is not using prophylactic intermittent dialysis for contrast in patients with increased risk of CKI. Now the whole point of delivering this talk is that I'm going to present a realistic view. The view which was there, through the ages that, there is something which is called contrast induced. So actually, the debate started that does contrast induced nephropathy, does it really exist? So we moved from contrast induced AKI to contrast associated AKI. So there are a lot of clinical settings that is contrast associated AKI, that is any AKI which is occurring 48 hours after administration of contrast media. And there were some trials which were there which suggested that really we need to think about it. This was a trial in which around 32,000 patients who were hospitalized and their creatinine was followed. Even if they were not giving any contrast, there was some rise in creatinine even during their admission because of various reasons. So why was contrast implicated? That was a question. Then this was also a trial which suggested that risk of AKI without contrast is 5.6 and with contrast is 5.1. So risk of contrast associated nephropathy may be overstated in literature and overestimated by clinicians. So more accurate AKI risk estimates may improve clinical decision making. And this led to a concept which is called renalism. Renalism was when we were so particular of not giving contrast that a lot of patients were based off, the contrast procedures which were there to save his life. So there are a lot of evidence, so I have to rush fast. And this was a recent paper. Now, a lot of times your cardiologist colleague will ask you that we are having a history of AKI. Can we use contrast or not? So this was a paper which suggested that among patients with pre-existing AKI, contrast administration was not associated with either persistent AKI at hospital discharge or initiation of dialysis within 180 days. So, current consensus recommendations for use of IV contrast in patients with stable disease may also be applied to patients with pre-existing disease. Even, in emergency settings also, when we were supposed to be, contrast pulmonary angiography and other procedures, there was no evidence for harmful effect of kidney function on IV contrast administered for CTPA or emergency setting. Now, debates versus intravenous versus intra-arterial. There are some people who suggested no difference, or some suggested that it was more with intra-arterial. So this was our latest recommendation in 2020, which suggested that you divide patients on the basis of GFR who are going to go for the contrast procedure. If GFR is less than 30, prophylaxis is indicated. If it is more than 30, highly no prophylaxis is indicated. In patients who are in the GFR range of 30 to 44, prophylaxis may be considered on the discretion of clinician. Then what is the prophylaxis? IV saline. Depending on the volume status of the patient, one should be less aggressive if you have evidence of heart failure and all. Now, I would like to end my talk with a thought to ponder for my cardiologist colleague. That even in those with eGFR less than 30, why to go for a invasive procedures when current evidence suggests that invasive treatment did not reduce the rate of death or non-fatal MI or improve angina-related health issues in patients with advanced renal failure. But then that discussion is there. So in emergency setting, the overall approach is if you see a critically ill patient who needs a contrast imaging, what is the GFR? Actually forget it. In emergency setting, we don't really care. Go for contrast, it is good for the patient. So my take home is that CI remains an important clinical issue, even though overstated. A team approach is of utmost importance. In high-risk alternative, non-Ayurvedic contrast study should be considered. High-risk patient and contrast imaging studies deemed absolutely necessary. Access. More adequate power studies are required. Stop with life-saving procedure is there. Thank you.
Toxicity.
Thank you, sir. Thank you, Dr. Om, for those kind words. And I want to thank the organizers of Ccdsicon for inviting me to this prestigious conference and letting me explore this wonderful city of Begusarai. So I will be starting with my topic. My topic for the day is emerging therapies for the management of cardiorenal syndrome. So why should we talk about this? We should talk about this because CKD, as you know, is increasing daily. As we are progressing more and more in our treatment for cancer and for other cardiovascular diseases, and our population is aging. So CKD is increasing. And as you can see, this is the chart from ISN. And even though this is 2022 ISN, but however, it is showing the data of 2017, and in 2017 itself, there were 850 million people across the world who were suffering from CKD. And as we progress in 2040, there will be CKD causing death will be the fifth largest reason for mortality in the world. Now, why is this important? Because as CKD, as you can see, as the CKD stage increases, the chance of developing cardiovascular disease increases. That can be both, and the patient will be, person will be prone to both atherosclerotic cardiovascular event as well as more prone to non-atherosclerotic cardiovascular events in the form of left ventricular hypertrophy, arrhythmias, sudden cardiac death. And as the different stages of CKD increases, as you can see, when stage 1 and 2 compared to stage 4 to 5, the all causes heart failure, which is both systolic and diastolic, increases in these patients. Now coming to how does CKD lead to what does CKD cause? So everyone with CKD is afraid that they will undergo dialysis. However, you should know that the 5-year probability of having a death because of cardiovascular disease in a CKD stage 4 and 5 is 33% compared to only going for dialysis is 12% in these population. So there is more chance that the population of CKD 4 and 5 will have a cardiovascular event or a cardiovascular mortality as compared to reaching end-stage kidney disease and undergoing dialysis. Now, what about heart leading to kidney problems? As you know, as a patient with heart failure, he will have a rapid eGFR decline as compared to a patient who is not having heart failure with concomitant CKD, with a decline of 22% compared to 9 ml per year. And a patient with incident CKD and heart failure will have a higher mortality. That is why this topic of cardiorenal syndrome is so important for us. So the first person to describe cardiorenal syndrome was not Professor Arthur Galton, but actually it was Robert Bright. who first described this syndrome in 1836 when he was describing the Bright's disease or the albuminuria. He found out that the patients who were having increased albumin in urine, on autopsy, they were having the increased heart muscle as well, which was like a hypertrophic cardiac muscle. But this was described, cardiorenal syndrome was described in detail by Professor Arthur Guyton, who talked about the cardiac output, the role of kidneys, hypertension, and the crosstalk between the heart and the kidneys. So what is the exact definition of cardiorenal syndrome? It is a disorder of in which the heart or kidney, disorder of the heart and kidney, whereby the acute or chronic dysfunction in one organ can cause acute or chronic dysfunction of the other. So the organ that is involved first is known as primer movens, and based on that, we have divided the cardiorenal syndrome into the 5 classifications. These 5 classifications were given by Edo-Key, and especially by Professor Ronco had given a lot of work in these classifications. And they have divided the classification into 5 types. Type 1 and 2 are the ones in which the primer movement or the first organ to be affected is the heart, and that leads to kidney failure. That is acute cardiorenal or chronic cardiorenal. Type 3 and 4 are primer movement being the kidney, that is acute renocardiac and chronic renocardiac syndrome leading to heart involvement. And type 5 is when there is a systemic involvement which is leading to both heart and kidney dysfunction. For example, being sepsis, amyloidosis, or say diabetes. The only thing that you need to know that these are not compartmentalized. These classifications are not compartmentalized. A patient can have at one moment of time either one or both or maybe several of these. For example, a patient who is having currently chronic cardiorenal can, that is chronic congestive cardiac failure leading to AKI. If this AKI is not resolved, he can go into type 4, that is he can have an AKI with CKD and he can have a chronic renocardiac syndrome. Or the patient with chronic renocardiac syndrome can be diabetic and therefore can have type 4 and 5 together. So we need to know that this is not a compartmentalized classification. Now, I was told that due to a paucity of time, I should not dwell much into the pathophysiology, but we need to know a little bit about pathophysiology so that we can start the treatment for the patient. The 3 important mechanisms which play a very important role in the pathophysiology of cardiorenal syndrome are hemodynamic mechanisms, neurohormonal mechanisms, and inflammatory mechanisms. So hemodynamic mechanisms, we all know about left heart failure, and we all know that left heart failure causes a forward failure in which there is a decreased ejection fraction, which leads to decreased cardiovascular flow in the kidney, and therefore you can have a kidney failure. But you also need to know that sometimes the right-sided failure can also lead to congestion, which can lead to a renal hypertension. And this renal congestion or the renovascular hypertension is supposed to be causing more damage to the kidney. And this is what is the condition that we see in heart failure with preserved ejection fraction, where the right-sided is affected more than the left side. Other things are, as we know, because when there is decreased renal perfusion, it can lead to RAS activation, and it can also cause the activation of sympathetic nervous systems. So this is how the heart is affecting the kidney. Kidney, however, on the other hand, if the patient is having CKD, as we know, CKD is an inflammatory stage. It can lead to chronic inflammation, malnutrition, FGF23 can be released, and that itself can cause more calcification and lead to heart failure. So who are the patients at risk for cardiorenal syndrome? Patients at risk are those who have a pre-existing CKD, who have a pre-existing heart failure, who are diabetic, who are aged, and who have anemia. So we have a lot of organizations, the heart organizations, the kidney organizations, who have given us suggestions, but there are no proper guidelines on how to manage the cardiorenal syndrome. So before starting the actual drug treatment, this is something that you should follow in all the patients. That is, first thing, these are the non-drug related therapeutic managements. That is smoking cessation. That should be called for all the patients. Blood pressure control. According to the SPRINT trial now, the blood pressure should be less than 120/80. But in our CKD patients, we will still give it a little more higher margin of at least controlling the blood pressure to 130/80. Lipid management should be there according to the atherosclerotic cardiovascular disease score of less than 10%. If it's more than 10%, start statins. Then weight management, tell the patient to reduce weight. And one more important thing that we don't manage mostly in our patients is vaccination. So these patients are very prone to get LRTS. So it will be advised that these patients should have a regular influenza vaccine, yearly vaccinated. So this was the treatment protocol that was followed earlier. That was actually a stepwise protocol. That is, you start with loop diuretics, add beta blockers, add ACE inhibitors, and then give them to the highest dose. Then, if not responding, give MRS. And still, if the heart rate is higher, give ivabradine. And if the patient is symptomatic, you can give either implantable cardiovascular defibrillator, or you can give CRT, or in the end, heart transplant. However, now, according to the 2019 papers, you don't need to go for a stepwise approach. You can start all the things immediately, and and then follow up the patient and increase the dose gradually. So these are the treatment strategies for cardiorenal syndrome, starting with decongestive therapies in the form of diuresis and ultrafiltration, neurohormonal modulation and vasodilator and inotropic therapy in the form of nesiritide, tolvaptan, and dopamine, RAS inhibitors in the form of ACERBs, ARNIs, MRAs, and beta blockers, and the cardiorenal syndrome and type 2 diabetes, which will be SGLT2 inhibitors. So starting with the diuretics, there was a very important trial called the DOSE trial, which wanted to see how much diuretics should be given and whether they should be given in a continuous dose or a bolus dose. So we divided the patients into 2 by 2 factorial, in which they give one set of patients normal dose of diuretics that they were on initially, and the other set of patients got a high dose diuretics, that is 2 times the normal dose, oral dose, and one set was given a bolus infusion and one set was given a by 12-hourly bolus dose. One set was given a continuous infusion and the other set was given a bolus dose. And they found that actually, even though the patients who were given high dose diuretics and a bolus dose symptomatically felt better, but there was at the end no difference in the primary endpoints. So there were other data, other analyses that also showed that if you give a stepwise goal-directed diuretic algorithm and try to decrease the weight by around 2 to 3 kgs with a urine output of 3 to 4 liters by giving step diuretic management, it is ultimately helping the patient. And high-dose intermittent furosemide is therefore safe and effective, and that is what you should be given. Continuous infusion does not provide any further advantage. So after this, they tried to see, instead of diuresis, if we can give ultrafiltration. So there were many studies, and one of the important studies was UNLOAD study, which actually showed that ultrafiltration has some benefit in preventing the rehospitalization of patients. However, there was a lot of criticisms regarding the study because firstly, they did not give the higher dose of diuretics, and secondly, it was actually sponsored by the company which was there for the ultrafiltration. The other studies, especially the CARIS-HF study that has been done, provides a strong argument against the use of ultrafiltration as a primary treatment for any type of CRS. And everyone, ultrafiltration is given only if the patient is not responding to the highest levels of diuretic that you are given or is gone into oliguric acid, then you can start ultrafiltration. Now coming to neurohormonal modulation in the form of tolvaptan and nesiritide. So in tolvaptan, a lot of studies have been done. However, they have not shown to be much benefit, though Japanese cardiologists and nephrologists do use tolvaptan, especially in patients who do not show response to diuresis. Other thing is that nesiritide and dopamine has also been tried on these patients. But however, at the end point, they have not shown any significant improvement. Now coming to something that we know that does show improvement, that is ACE and ARBs. So as you know, a lot of studies have been done for the use of ACE in ARBs in cardiorenal syndrome, including the important and famous consensus study and the SALT study. And both have shown that ACE and ARBs, even though they may increase the creatinine to a certain level at the beginning when you start the diuresis and you start ACERBs, but at the end, if you continue with ACERBs, the patient does have a mortality benefit. So, especially this is regarding ARBs also. ARBs have shown that with patients with reduced heart ejection fraction of less than 45%, EGFR less than 60%, if you continue ARBs, they have a significant reduction in all-cause mortality. So, should we stop ACERBs at some creatinine level? No. There's been a trial called the STOP ACE inhibitor trial, in which they either continued the RAS inhibitor up to stage 4, after stage 4 and 5 also, or they discontinued RAS inhibitors when the people reached stage 4 and 5 CKD. They found that there was no difference in the increase of EGFR, fall in EGFR, but however, there was a better outcome in people who continued ACERBs, and there was decreased MACE events in these people. So these are some of the studies regarding ARBs. This is the same as I told earlier. In patients with heart failure with reduced ejection fraction, you should continue ACERBs unless there are some very strong indicators like the patient is having uremia or the patient is hypotensive or in shock, then only you should stop. For hyperkalemia, you should manage the causes of hyperkalemia, see for any other cause, try to prevent hyperkalemia before starting ACERBs. Now coming to ARNIs. ARNIs are very famous among the cardiologists. However, nephrologists have not used ARNIs so much. But there have been trials, especially the Paradigm HF trial, which has compared ARNI with the AC inhibitors, and we have shown that ARNIs have a much better response. They have lesser EGFR, however the albuminuria increases. Nowadays, the latest guidelines are that ARNIs should be used in patients who are not tolerating ACERBs for some reason or the other. Now, after ARNIs, the next drug to be used is the mineralocorticoid receptor antagonist, out of which now we have mineraloreceptor antagonist in the form of eplerenone, and now the newer ones, which is the non-steroidal one, that is finerenone, and that has also shown to be of much benefit, especially to prevent the aldosterone escape effect when we give diuretics for a long time. Beta blockers. If someone has to ask what is the greatest study or greatest drug that has been used in cardiorenal syndrome in the last 60 years, that is the beta blockers. Beta blockers themselves have managed to reduce mortality by around 40 to 50% in patients with cardiorenal syndrome. The beta blockers that are specifically being used in these are metoprolol, bisoprolol, and carvedilol. So there have been many trials, the most famous being the MERIT HF trial, which has shown that you can use beta blockers up to class 4 heart failure with ejection fraction less than 40% and with EGFR even less than 45 ml per minute. Last but not the least, SGLT2 inhibitors. We have been talking about it since the starting of this program, so I will not be going into much detail. Just that SGLT2 inhibitors have shown a very good cardioprotective as well as renal protective effect, mechanism in both our patients with cardiorenal syndrome, and you know the mechanism in which they act against both the kidney, to prevent both kidney as well as heart damage. So these are the trials, and all the trials have shown very positive effect. So coming to my last slide, this is the ACC-AHA guidelines, and as you know, SGLT2 inhibitors are now the first line along with metformin for any diabetic patients. And these are the latest evidence-based evidence-based trials against for cardiorenal syndrome. As you can see, ACERBs, ARNI, MRAs, and beta blockers have strong evidence up to stage 3. Stage 4 and 5 also, we don't have actually much trials, but beta blockers can be used up to stage 4. And now we know that ACERBs can also be continued up to stage 4 and 5 CKD. Other than that, digoxin and isoniazide dinitrate do not show much improvement. And CRT and ICDs are based on the cardiologist, and it has been said that if left ventricular ejection fraction is less than 35%, they are recommended. The things that I have not talked about are peritoneal dialysis, though we know that peritoneal dialysis can also help in patients with cardiorenal syndrome, but there have not been much studies regarding that. Another thing that is now in vogue is acetazolamide. That has also been told that it helps in cardiorenal syndrome, but the studies that have come have not been very promising, and we have to wait for future to see whether it helps or not. So thank you so much.
Thank you, Dr. Neha, for vast topic. And I would like to congratulate all and Mr. the God who likes the so I would like to do the ritualities giving the honor to all our speakers.
Thank you so much. Thank you for sharing.
Now we come to the end of this session. Thank you to every speakers.
Dr. Kumar will be on the chair of the particular session. And now forward to my speaker. और मैं एक ही बात मुस्लिम लोग भी हमारे डॉक्टर
कुछ नहीं आप बोले
So please read the And I would like to request to start this.
So, good afternoon. This is session particularly designed by the organizers for PG students. This is first time we are holding this type of meeting. The first speaker for this session is Dr. Rashmi Singh from Indira Gandhi Institute of Medical Science, Patna. She is PG in the Department of General Medicine. Dr. Rashmi Singh, you have 10 minutes. 7 minutes left. Okay. You have to finish it in 7 minutes. The topic is diabetic patient with acute coronary syndrome.
Good afternoon, honorable chairpersons, respected doctors. I am Dr. Rashmi Singh, junior resident of the Department of General Medicine, IGIMS. Today I am presenting a case of diabetic patient with acute coronary syndrome. 66 years old gentleman, resident of East Champaran district, farmer by occupation. He was a known case of systemic hypertension for 5 years, diabetes mellitus type 2 for 2 years, presented to the emergency department of IGIMS on 28th April 2023. The chief complaints were following: chest pain for 4 months with shortness of breath for 1 day. The history of presenting illness: chest pain for 4 months was intermittent in episodes, retrosternal in location, each episode lasting for 10 to 20 minutes, mild in intensity, aggravated by exertion, relieved with rest, and it persisting till 1 day before presentation. On the day of presentation, he had an acute onset of pain, which was severe retrosternal chest pain, radiating to both the shoulders, with sense of chest tightness and associated with profuse sweating. Dyspnea was present for 1 day, which was acute in onset, progressive, increasing with exertion, associated with orthopnea. There was no history of cough, expectoration, fever, syncope. Past history: known case of hypertension for last 5 years, taking telmisartan 40 mg plus chlorthalidone 6.25 mg OD. Known case of type 2 diabetes mellitus for 5 years, taking metformin 850 mg plus glimepiride 2 grams BD. There was no history of tuberculosis, asthma, COPD, rheumatic fever. Patient had a cataract surgery in right eye 5 months back. Family history: mother is a known case of type 2 diabetes mellitus. No known history of cardiac illness in family members. Personal history: no history of smoking, alcohol or IV drug abuse, vegetarian diet consumer, normal bladder and bowel history. Socioeconomic history: lower middle class according to the modified Kuppuswamy scale. Summary: so here it is a 66-year-old gentleman who was a known diabetic and hypertensive, presenting with a history of anginal chest pain for 4 months with acute onset severe retrosternal chest pain of 1 day duration with acute onset dyspnea associated with orthopnea. So my provisional diagnosis was coronary disease with acute coronary syndrome, left-sided heart failure, complicated in left-sided heart failure, NYHA class 4. On general examination, he was conscious oriented to time, place, and person. The height was 181 centimeter, weight 61 kgs, and the BMI was 18.6 kg per meter square. The pulse rate was 80 per minute, regular in and but low in volume. All peripheral pulses felt. No radio-radial delay or radio-femoral delay. No vessel thickening. The BP was 92 by 60 mm Hg. Respiratory rate was 36 per minute, abdominal thoracic type. Temperature was afebrile and the SpO2 was 88% on room air. JVP was 8 centimeter from angle of Lewis. Pallor, icterus, cyanosis, clubbing, lymphadenopathy, all negative. Pitting, pedal edema present in both lower limbs. On systemic examination, on inspection, the precordium is normal. Apical impulse, fifth intercostal space can be seen in the mid-clavicular line. No visible pulsation, no dilated veins or scars. On palpation, trachea position was confirmed. Apical impulse, left fifth intercostal space on mid-clavicular line was normal in character. No palpable thrills, heave, no palpable pulsation. On auscultation, S1 was normal. S2 was also normal with normal split. S3 could be heard in the mitral area with the bell of the stethoscope. There was no audible S4, no murmurs heard. And respiratory system examination, inspiratory fine clefts were present in the bilateral infrascapular and infraaxillary regions. Abdominal system, soft and non-tender, no organomegaly in the CNS system, he was conscious oriented. So the ECG we can see, there's QS complex in V1 to V3, ST depression, T-wave inversion present in the lead 2, 3 and AVF. The echo showed RWMA in the LED territory, no mitral regurgitation, no tricuspid regurgitation, and LV ejection fraction was 35%. These are the investigation. The HS tropi was 3,747, while the serum BNP was 1,393. The patient has HbA1c 9.4%. The chest radiograph shows the signs of pulmonary edema. So the diagnosis was a coronary artery disease, acute coronary syndrome, anteroseptal MI, which had a delayed presentation, complicating into acute left ventricle failure, NYHA class 4, CLIP class 2, and normal sinus rhythm. Risk factors were age, systemic hypertension, and type 2 diabetes mellitus. On the day of admission, the patient was managed with moist O2 inhalation to keep the target SpO2 above 92%. Tablet clopidogrel 300 mg stat with 75 mg per oral was given. Tablet aspirin 300 mg starting 75 mg per oral was given. Tablet atorvastatin 80 mg starting 40 mg ODHS, while injection low molecular weight heparin 60 mg subcutaneously BD was given. Tablet nicorandil 5 mg per oral BD along with injection furosemide 40 mg IV stat followed by 20 mg IV BD was given. Injection regular insulin subcutaneously 644 units was given, and injection pantoprazole 40 mg IV OD was added. On day 2, coronary angiography was and PCI was planned. Patient was loaded with 2 tablets of ticagrelor, 90 mg stat and then BD, and Orsiro 13 to 45 mm stent was placed in LAD, and Orsiro 15 to 25 mm stent was placed in right coronary artery. This is the coronary angiography report of the patient. On day 3, the patient was stabilized and need for the oxygen support decreased. The patient BP, pulse rate, they were all in normal range. Day 4, the most medications were changed into oral form. And on day 5, the patient was discharged with the following advices. Tablet ticagrelor 19 mg per BD, Ecosprin tablet 75 mg per oral OD, tablet torsemide and spironolactone, the combination of 10 by 50 half tablet OD to be taken in the morning. Tablet atorvastatin 40 mg per oral to be taken at the night. Metformin 850 mg with tablet glimepiride 2 gram before breakfast. Tablet dapagliflozin was added 10 mg OD. Ramiprid 2.5 mg OD. Tablet metoprolol succinate was started from 12.5 mg OD, and tablet nitroglycerin 2.6 mg BD. Along with that, tablet Fantop 40 mg was given. Review in cardiology OPD was advised. So the summary is that diabetes mellitus increases 2-fold risk in males and 4-fold risk in females for heart failure. Hypoglycemia, insulin resistant, and hyperinsulinemia. All these three play the central role in pathogenesis of heart failure and diabetic patients.
Dr. Rashmi, please conclude.
Okay, sir. And so heart failure, and an interesting thing is that even heart failure is also a risk factor for diabetes mellitus. So lifestyle management and SGLT2 inhibitors have been a preferred glucose lowering agent in all patients of heart failure, and the target HbA1c should be less than 7%. That's all. Thank you, everyone.
Why did you suspect it to be a case of acute coronary syndrome? There may be other causes, acute chest pain with sudden onset dyspnea. What are the other causes of paroxysmal dyspnea?
So the causes of, so the patient can present with aortic dissection. Paroxysmal, so can you repeat?
Paroxysmal dyspnea. Acute onset dyspnea.
Yes, sir. So pulmonary embolism can be a cause of paroxysmal.
Just wait. How do you differentiate between massive pulmonary embolism and acute cause? In both the cases, the patient will present with paroxysmal dyspnea, means acute onset dyspnea.
Yes, sir.
Or sudden onset dyspnea with acute chest pain. Your stetho will help. Yeah. Thank you.
One more question. You have told that apex beat was in the fifth intercostal space and the patient was having ACS. So I don't think it can be localized. Ideally, it should have been diffuse apex. BP was also low, so it can't be localized in that case.
Yes, sir.
And why did you use OHAs in ACS? You should have used insulin.
Sir, I have used insulin in the when the patient was admitted, but when we discharged the patient, then we gave him insulin.
Okay.
Why you have not thrombolized it? Simple. Why you have not thrombolized? Simple.
So because we are a PCI equipped center, so when the patient arrived, we and the patient arrived after 12 hours. So so the patient has arrived after 12 hours. The time has passed, so therefore we prefer PCI over.
Okay, thank you, Rashmi.
Thank you, sir.
The next speaker is Dr. Anjali Kumari. She is also from Indira Gandhi Institute of Medical Science and she is junior resident in the Department of Medicine. The topic is a case of 75-year-old diabetic man with acute decompensated heart failure.
Good afternoon, Honorable Chairperson and the respected doctors present here. I am Dr. Anjali Kumari, PG Second Year, Department of General Medicine. I am here to present a case of 75-year-old diabetic man with acute decompensated heart failure. Heart failure. What is heart failure? According to College of Cardiology Foundation, American Heart Association and Heart Failure Society of America, guideline defines heart failure as a complex clinical syndrome that results from any structural or functional impairment of ventricular filling or ejection fraction of blood, leading to cardinal manifestation of dyspnea, fatigue, and fluid retention. Heart failure, why it is a concern? Okay, sir. A patient named Chandeshwar Singh, 75-year-old male, resident of Sitamarhi, unemployed, informed its patient himself, presenting complaint, difficulty in breathing since 1 year, bilateral lower limb swelling, on and off since 6 months. History of presenting complaint. Patient was apparently normal till 1 year back when he started developing breathlessness on exertion. It occurred on climbing 2 flights of stairs, which he was able to climb previously without any difficulty, class NYHA2 symptoms. It was relieved by rest and progressed over past 1 year, such that he now has breathlessness on exertion even on walking on level ground for a few minutes, class 3 NYHA symptoms. History of worsening of dyspnea on lying down, that is orthopnea, and history of symptoms suggestive of PND, and all symptoms got aggravated since 2 to 3 days. No history of bloodlessness at rest, no history of associated wheezing, no history of fever, cough, and hemoptysis. Patient past medical histories were type 2 diabetes mellitus on OHA with visual complications and chronic kidney disease, and a known case of hyperthyroidism and was on Thyrox 25, was admitted 3 months ago on October 22. He had dyspnea on exertion, NYHA3, orthopnea was present at that time also, a diagnosis of CAD with severe LV dysfunction with reduced ejection fraction of 25%. He had hypertension since approximately 5 years ago. However, the patient doesn't take medication regularly. When the patient headache, he only took the medicines he bought himself at the shop and rested. Patient has also had diabetes since approximately 6 years ago. The patient routinely took a blood sugar lowering drug taken every morning after first, he didn't remember. Patient family history include hypertension and type 2 diabetes mellitus in his mother. His father had a heart disease. The patient was a previous smoker for 15 years and a chronic alcoholic and has stopped smoking since 20 years ago. During physical examination, patient had dyspnea, was hydrated, didn't have fever, got good peripheral perfusion, blood pressure was 100/70 and a pulse rate of 90 per minute, and 92% oxygen saturation. There was jugular turbulence, chest was bilateral symmetrical, vesicular breath sound was present, presence of crackles was present in both the lung bases, normophonetic, rhythmic sounds, in 2 stages without murmur. There was no hepatomegaly. Patient abdomen was flaccid, painless, and bowel sound was present. The lower limb presented +2 pedal edema or +4 edema. The calves were free, and there were symmetrical pedal pulses. Laboratory parameters include hemoglobin of 9.3, total count was 8,2100, platelet count was 3,30,000, one was 29.2, creat was 4.3, HbA1c was 6.7, and BNP was 2,707 with tropi 38.7. Electrolyte, sodium was 134, potassium was 4, chloride was 90. ECG revealed a sinus rhythm, low voltage of QRS complex in frontal pain and ST segment depression 1 mm horizontal from V2 to V5 and a reduction of left ventricular potential. Echocardiography was suggestive of CAD with ejection fraction 35% and a chest radiograph showed cardiomegaly, bilateral minimal effusion with prominent vascular markings. These are the ECG and chest X-ray showing cardiomegaly with pulmonary congestion. During hospitalization, the patient had dyspnea and signs of pulmonary and systemic congestion. The patient was given infusion furosemide 20 milligram 1 ml per hour over 24 hours. Tablet cilnidipine 10 OD, rosuvastatin, aspirin, and clopidogrel 75 10 and 75 tab. Sodium bicarbonate 500 milligram tab, dapagliflozin 10 OD, and metoprolol 12.5 OD, and Thyrox as he was taking before. Patient was given education to bed rest, limit fluid intake per day so that the patient's workload is not heavy, diet low in salt, that is 1.5 gram per day, and limit excessive sugar consumption. After 5, physical action showed that respiratory rate turned normal, the pitting edema and effusion were reduced. Patient went home from the laboratory results are stable, was informed to take medicine regularly and control every month. Diagnosis of heart failure is confirmed based on the history and physical examination and laboratory investigation. The Framingham criteria for diagnosis of heart failure require the concomitant presence of 2 major, one major and 2 minor criteria. This include major criteria and minor: acute pulmonary edema, cardiomegaly, hepatojugular reflex, neck vein distension, paroxysmal nocturnal dyspnea, orthopnea, rale, and third heart sound or gallop sound. Minor criteria were ankle edema, dyspnea on exertion, hepatomegaly, nocturnal cough, pleural effusion, tachycardia, more than 120 beats per minute. Patient had a history of type 2 diabetes. Insulin resistance is a significant risk factor for development of heart failure. Presence of diabetes mellitus significantly increases the development of heart failure in patient without structural heart disease and has a negative influence on outcome of heart failure.
Final diagnosis. Last slide. Final diagnosis.
Final diagnosis is an acute decompensated heart failure in a type 2 diabetes mellitus. And conclusion is early and accurate diagnosis is crucial so that the treatment may start immediately to prevent severe complication. Therapy for risk factor can slow the progression of heart failure. Patients are recommended to take medicine routinely, to exercise regularly, and change diet and lifestyle.
Okay, Anjali, you have written third heart sound with gallop. What is the difference between third heart sound and gallop?
S3 and S4 are said to be gallop rhythms, sir. It is used interchangeably.
Any heart sound associated with tachycardia is gallop. Do you agree?
Actually, in your first slide, you have shown that the patient complains of shortness of breath for 1 year and for 6 months.
Yes, sir.
So these are the 2 presenting complaints.
Yes, sir.
Why did the patient come to hospital? Ideally, you should have added shortness of breath also in the presenting complaint. For 3 to 4 days prior to hospitalization, that should have been added in the presenting complaint also.
Okay, sir.
Okay. How do you differentiate between PND and orthopnea?
Orthopnea is a short duration symptom, sir. On PND, patient suffers PND after 2 hours of sleep because of the exudation of the fluid. Patient complains or feels like he is deficient of breathing.
Really make it simple. What are the signs of heart failure in your patient? Positive heart failure signs in your patient.
Dyspnea on exertion. Orthopnea.
I have asked about signs.
Yes,
what signs?
Orthopnea, PND, raised jugular venous pulses, and bilateral pedal edema.
Anything else?
Basal cracks are present, sir.
Where do you compress to demonstrate abdominal jugular reflex? Which part of the abdomen should be compressed?
Mid of the chest, sir.
Or chest.
Or it can be pressed at the hepatojugular reflex.
The compression is not done in the chest, or it is within the epigastrium, not in the hypochondrium.
Gastric region.
It is in the epigastrium.
Thank you, Anjali.
Thank you, sir.
Now the next speaker is Dr. Ajinkya from All India Institute of Medical Science, Patna. His topic is hypoglycemia in emergency room.
Hello. 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 पीछे मारो, पीछे मारो, पीछे 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 बैक बैक नहीं मारना। Good afternoon, everyone. Respected stage, below teachers, and my dear friends. It's been a pleasure presenting a case of hypoglycemia in emergency room. So what we have done, we have evaluated all the patients of hypoglycemia which came to our emergency department, and we have evaluated what were the associated risk factors so that patient came into emergency room. So as we all know, the hypoglycemia is one among the leading causes for emergency medicine, emergency department visits, as well as it is the most common and easily preventable and in emergency. So with increasing evidence of diabetes and with the various modalities of intensive control of blood glucose level, there is always a risk of proportional increase in the incidence of hypoglycemia. As the prolonged duration of hypoglycemia may lead to significant morbidity as well as mortality. So each hypoglycemic episode should be addressed accurately in the aspects of etiological diagnosis as well as preventive measures. So what were the aim? Actually, we have, it's like a more of a study what we have conducted. It's a pilot study, and the aim was aim was assessing the prevalence as well as evaluating the underlying causes of hypoglycemia in emergency room, as well as associative factors with hypoglycemia. It was a prospective and pilot study which we had been done in emergency department. So the materials and methods were, it was a prospective as well as observational study and pilot study. We have included all the patients in emergency department with blood glucose of less than 70. The department ethical clearance was taken before the study. Patient age was more than 15 years at the time of arrival, as well as blood glucose less than 70 were included into the study. And this study was conducted from 14th of March to 13th of March, and those with inadequate data were excluded from the analysis of the cause of hypoglycemia. So the data collection method was on arrival patient's identification number, as well as blood glucose, their values, age and gender of the patients was noted. Patient's clinical data, it was data from previous reports. So the patient presented with signs and symptoms of hypoglycemia like giddiness, sweating, palpitations, altered mental status, seizures, syncope, paresthesias, numbness and motor deficits. So results.
So our results was out of total 56 patients who presented with hypoglycemia, we have found that male were 32 and female were 24. And out of all the 54 responses, what we have found that 51.9% were non-diabetic, along with hypoglycemia, and 48.1% were diabetic, and 54% were non-hypertensive, and 46% were hypertensive. So the hypoglycemia was more common in non-diabetic as well as non-hypertensive patients. This was the RBS response. So the 44.6% they presented with blood glucose of 60 to 70, followed by 19.6% in the range of 40 to 50 and onwards. So the lowest RBS which was found was 15 milligram per deciliter. So the signs of hypoglycemia, what we have included are the 41.2 patients they presented with altered sensorium, 11.8% presented with coma, and 9.8% presented with palpitations, and less than 5% they presented with tremors and seizures. Out of all the 26 responses, out of all the diabetic medication in the diabetic group, what we have found that the 34.6% patients they were having hypoglycemia in sulfonylureas group, and 19.2% they were on insulin, and 19.2% they were on DPP4 inhibitors, and 11.5% they were on bigonate. So we have to be very cautious because 34.6% patient who were on sulfonylureas, they were causing hypoglycemia. And these were the diabetic drugs which were causing maximum hypoglycemia. So the combination like metformin plus glimepiride along followed by sulfonylureas alone, insulin alone, insulin plus metformin, followed by glimepiride plus metformin. Out of this metformin plus glimepiride, they were causing maximum hypoglycemia. So the others, what we have found the associative risk factors like 24.5% patient they were having association with chronic liver disease, followed by 11.3% they were having associated with sepsis with hypoglycemia. 24.5% they are not having any of these symptoms. They are not having associated with features like CLD, sepsis, CVA, CHF, malignancy. So in CLD, there might be possible because of impaired hepatic gluconeogenesis, followed by there is decreased glycogen, depletion of glycogen storage. So in the diabetic group with hypoglycemia, what we have found out of total 25 patients, 16 were male and 9 were females. And out of in the diabetic group, out of 25 patients, what we have found the 11 patients they were hypoglycemic because of OH-induced hypoglycemia. Followed by 4 patients they are having CKD, and 3 patients they are having CVA, and 2 patients having CLD, followed by malignancy, and none of the who, and 1 patient were having sepsis. Out of in the non-diabetic patient which presented with hypoglycemia, out of total 30 patients, 17 were male and 13 were female. The total causes of hypoglycemia non-diabetic, what we have found out of 30, the 9 patients they were having CLD, followed by sepsis, followed by TB, malignancy, and thereafter. And associated with out of 54 response, what we have found 63% they were non-alcoholic as well as non-smoker. Only 29.6% they were alcoholic. So the discussion is the underlying causes of hypoglycemia in diabetic group. It can be because of intensive content of blood glucose, either by hypoglycemic agents or by insulin, or by the insulin plus oral hypoglycemic agent. Whereas in the non-diabetic group, it might be it was mostly because of CLD, sepsis, CKD, and CVA, and other like malignancies, infections, and unknown causes. So the conclusion is hypoglycemia is mainly because of medication related in diabetics, that is OH related, and CLD and infection is the leading cause in non-diabetics. And CLD will be hepatic gluconeogenesis, followed by depletion of hepatic glycogen storage. Whereas in CKD there might be impaired renal clearance of insulin because of that. Hypoglycemia might be occurring, as well as because of renal impaired gluconeogenesis. So the strength were we have evaluated the risk factors as well as we have found out the association. Also the combination of antidiabetics like metformin plus glimepiride, which were causing severe hypoglycemia, which has been found out. So the take-home message was none of the patients should leave the ED without the proper evaluation of etiology of hypoglycemia, and the problem should be addressed at each individual level. Thank you.
What are the order differential diagnosis?
Sorry, sir?
Mimicking the symptoms of hypoglycemia.
Sorry?
Differential diagnosis.
Differential
mimicking the symptoms of hypoglycemia.
So CLD,
sepsis, CKD, CVA,
Acute conditions.
most of them they were having like skip meals also. The patient having blood glucose level recurrent falling down of glucose.
What is the cause of hypoglycemia? It is more common in CKD patients. CKD patients, it is more common.
CLD as well as CKD.
So why is it more common in CKD?
Sir, maybe because of impaired renal gluconeogenesis followed by impaired excretion of insulin, or it might be because of impaired excretion of diabetic drugs because of kidney failure.
What drugs are safe in renal failure?
Sir, gliptin groups can be given.
Which gliptin?
Sitagliptins. Linagliptins.
Thank you. Now, the last speaker, Dr. He is from Patna Medical College Hospital and a junior resident in the Department of Medicine. His topic is a case of pulmonary Langerhans cells histiocytosis.
Button, sir. Good afternoon, honorable chairpersons, all the doctors present here, and my dear friends. I'm Dr. Souvik Chatterjee. Is going to present a probable case of pulmonary Langerhans cell histiocytosis admitted under our head of the department, Dr. P.K. Agarwal, sir. Patient's name is Mohammad Dilshad, 16 years male, resident of Darbhanga, is 7th class school dropout, unmarried, got admitted in PMCH emergency department and then to our respiratory medicine ward on 3rd March 2022, and then was examined by me on 10th March 2022. Informant being himself and his mother, and is of lower socioeconomic status. He came with the chief complaints of cough with expectoration for 4 months, anorexia for 2 months, shortness of breath on exertion for 1.5 months, on nasal cannula oxygenation with chest pain, weight loss of 5 kg in 2 months. Patient was asymptomatic when he resided in Jaipur with his brother and walked in local shop 7 months back. He was then captured by Rajasthan police and kept in custody for 4 months. 2 months post-release in November, he developed cough with expectoration, whitish 2 to 3 teaspoonful, and fever, low grade without chills and rigor and continuous. Treatment was sought from local practitioners, but symptoms didn't subside. After 1 month, patient developed shortness of breath, gradual in onset, progressive in nature, present on hurrying on level ground or climbing upstairs, MMRC grade 1. No diurnal variation present, no V's present. Patient continued seeking medications from local practitioners. Shortness of breath was accompanied by dull aching chest pain, more towards the right side than left side. Exacerbated on coughing and got temporarily relieved by antitussive prescribed by the local doctor. In February, when there was sudden exacerbation of shortness of breath, his family decided to take him to a private hospital in Darbhanga. Patient was inserted intercostal chest drains bilateral and given symptomatic treatment. The cause of ICD insertion was unknown as patient couldn't produce any documents for the same. He denied any history of violent coughing, trauma to chest, lifting of heavy weight, violent vomiting or retching. He had no history of hospitalization or any medical or surgical procedure in the recent past. No previous history of breathlessness was elaborated by the patient. No significant past or treatment history except for treatment received in Darbhanga.
Personal history is significant since he was an alcoholic and toddy consumer occasionally and also smoked 3 to 4 cigarettes on average per day. General examination revealed poor nourishment with thin and toxic look. Pallor and grade 1 clubbing was present. Vitals were normal during examination except for an increased respiratory rate of 30 per minute with the use of accessory muscles. Upper respiratory tract was normal. On inspection, there was reduced bilateral chest movements with intercostal fullness. Apical impulse couldn't be visualized due to presence of ICD. On palpation, there was diminished movement bilateral, right more than left. Trachea was deviated towards the right with reduced vocal fremitus bilateral, right more than left over inframammary, axillary, infraaxillary, and infrascapular areas. On percussion, tympanic note was heard bilateral, right more than left over same areas of reduced vocal fremitus with obliteration of liver dullness. No shifting dullness was present. On auscultation, diminished vesicular breath sounds were heard bilateral, right more than left, with diminished vocal resonance bilateral over inframammary, axillary, infraaxillary, and infrascapular areas. Coarse crests were present bilateral over mammary and interscapular areas. No rhonchi or pleural rub was heard. Other systems, CVS, GIT, CNS were within normal limits. Preliminary workup and with routine tests and chest X-ray, he was diagnosed to have pulmonary COX, clinico-radiologically diagnosed with secondary spontaneous pneumothorax bilateral. This was the initial X-ray which we conducted on 28th March 2022. We can see fibrobronchiectatic changes and infiltrations, but characteristically sparing of bilateral ostrophrenic angles. On 27th April, based on clinical evaluation, we removed the right-sided ICD and then did a chief X-ray. Viral markers, rat for COVID-19 and sputum AFB was negative. Chest X-ray showed right-sided pneumothorax for which we again planned ICD insertion. This was the patient and this was our chest X-ray. Bilateral ICD in situ. Treatment given in PMCH was moist oxygen inhalation, injection amoxiclav, vancomycin, arzol, 4-FDC, cough suppressant, pyridoxine 40, doxovant, N-acetylcysteine, aciprofilin combinations, and 5 episodes of intrapleural povidone iodine liquid for pleurodesis was done, and injection hydrocortisone was kept on SOS. This is the diaphragm images of the same patient, HRCT chest, and it shows right-sided pneumothorax and presence of irregularly shaped cystic lesions and nodules in the upper and mid zones of both lungs. With sparing of bilateral claustrophrenic angles, there is interlobular septal thickening present. Areas of consolidations are seen with air bronchogram along with ground glassing, and mediastinal adenopathy is evident from the mediastinal window. Anticox was put on hold after 2 weeks and patient was eventually discharged after performing bilateral pleurodesis and removing both ICDs. Prednisolone was prescribed at a dose of 40 mg per day in spite of repeatedly trying to reach out to the patient. He is given mobile number, he was lost to follow up. Now talking about pulmonary LCH, it's a smoking related ILD characterized by monoclonal proliferation and infiltration of Langerhans cells. Clinical entities include Litter CV disease, pulmonary LCH, sir.
What is the basis for your diagnosis?
So basis for the diagnosis was his presentation and history. He presented with spontaneous pneumothorax. Actually, the ICD that was placed in private hospital of Darbhanga, we took meticulous history and found out that it was inserted for bilateral pneumothorax, which was spontaneous, and by taking the relevant history, we witnessed the cause of primary spontaneous pneumothorax. So our provisional diagnosis was pulmonary COX with secondary spontaneous pneumothorax. But after the HRCT images were obtained, we found that upper and middle zones of bilateral lungs were filled with irregularly shaped cysts and bizarre shaped cysts, along with the presence of pneumothorax.
Without bronchoscopy or without lung biopsy, you can't be definitely sure that it is pulmonary.
Yes, sir. It was possible case and in consultation with radiologist, he guided us.
Bronchoscopy you could have done over there.
Yes, sir. Actually, light source was a bit weak that time.
Histiocytosis.
Yes, sir.
How could you diagnose a case of Langerhans cell histiocytosis without it is a tissue diagnosis?
Yes, sir. Lung biopsy is the gold standard actually.
In this bar, you can get more than 5%.
Yes, sir.
That is also
Yes, sir. That is also diagnostic, sir.
could have been done.
Yes, sir. That was.
Now come to your X-ray chest.
This one, sir? Huh.
Diagnosis. What are the differential diagnoses?
Sir, firstly, pulmonary cox, possibly miliary pattern since it involves bilateral lungs, bilateral fibrobronchiectatic changes, and other cystic lesions can be ruled out from this chest X-ray.
Thank you.
Thank you, sir. Yes, sir.
How do you define miliary shadow?
So miliary shadow is any shadow in bilateral lung fields 1 to 3 millimeter in diameter.
Thank you very much.
Thank you, sir. I will congratulate all our friends and
Second.
I request all the Rashmi
नहीं रश वहाँ है उधर पे लिखिए फर्स्ट सेकंड
आप लोग को दे देंगे सर
चलिए लाइए अनाउंस कर देते हैं बुलाइए So I request Dr. Rasmi Singh, Dr. Anjali Kumari, Dr. Ajinika and Dr. Somik to come over the desk. Before announcing the result, I would suggest not to be depressed. Oh, who is first, who is second, who is third, who is fourth. The best thing part of is that you presented the case. That is all. So the first is Dr. Rasmi Singh from IGMS. Second is Dr. Ajinika from AIMS. Third is Dr. Anjali Kumari from IGMS. And fourth is Dr. Souvik from Patna Medical College. The second. अपना नाम आता
मोमेंटो भी देना
ये मोमेंटो ये Dr. Anjali. And Dr. Souvik. तुम इसको पैथोलॉजी में एमडी थोड़े कर रहा है उनको पहचानते हो सबसे मिला करो वो नहीं पहचानेंगे तो किसको so thank you everyone and this is
also
now
Advance of exercise. Okay, it was nothing. Thank you, sir.
So I would like to thank the organizer and would seek permission to leave.
बहुत अच्छा किया, बहुत अच्छा किया। चलो हो गया बड़े खत्म।
So good evening, and to all our colleagues in the junior. It is time to say farewell and party with most of our heart. So once again, as we have gathered from different guests, they would try, people have challenged their past, and hopefully, all who have come here, but I with the academic content, and it must be said by them of it. We are very thankful to our dear academic figure, Dr. especially the scientific committee chairman, Dr. Ajit Kumar, Dr. Dinesh Singh, Dr. Vinay Kumar, Dr. P.K. Dr. S.K. Kumar, INA President, Dr. A.K. Rai, Dr. Ranjan Kumar, ED, IOCL, the Rajendra Kumar Chaudhary and his team for providing us a great venue to fulfill our aim. Honorable President Dr. N. Rai, who is in his late 80s, but still works like a young dog. And who has so much zeal, it is high and will individually and done to society who are also. And all who have contributed so simply and make it a success. At last, I will thank our veteran hearts who have given the whole and ceremony master Mr. Gupta is also to be come. That is the end of the discussion I will invite. And at last, no conference can succeed if every member and every person of the community thinks that this conference here is exemplified by the last 3 days attendance of here. So I am very, very grateful to them from the core of my heart. The dedication that will come.